Good morning, all. As the president of Solapur Academy of Pediatric, I welcome you all for this wonderful respiratory symposium. In this year of my presidency, we have conducted CME on various subspecialty topics like pediatric gastroenterology, hepatology, cardiology, endocrinology, neurology, behavioral sciences. Then we have decided to do CME on respiratory chapter. We approach one of the best person from respiratory chapter, that is Dr. Srikanta JT, who is working as an interventional pediatric pulmonologist at Bangalore. Along with him, we are also had eminent speaker, that is Dr. Sucheta Poffe madam from Umarga. Dr. Sunil Vaidya sir, he is HOD of Ashwini Rural Medical College. He has agreed to come for this CME, but due to some personal problem, he is not coming and not able to join today. Sir's lecture is uploaded on your Solapur Academy of YouTube channel. Last lecture is uploaded. Then Dr. Sandeep Kulkarni sir, Dr. Rajeshwari madam, and Dr. Mahesh Arkal from Solapur, and Dr. Abhay Patil from Tuzapur. All the topics are useful in our day-to-day practice, in OPD practice. And who other than Dr. Pratibha Patil madam would be coordinator for this respiratory CME symposium. And madam has also accepted gracefully and readily. We all know her passion to work for respiratory diseases. I will request madam to come on dais and take academic activity further. Over to you, madam. Be ready for great academic extravaganza.
Good morning, all. Good morning on this wonderful Sunday morning. I'm really thankful for all of you for giving time for the learning things. This will be the wonderful academics, respiratory academics. When Kundan sir told me you also take one topic as a faculty, I told him I want to be a student today. As Dr. Shrikanta, I want to learn from him. I would like to be a student of him today. And then other speakers are also very nicely prepared and already expert in their field. So our first speaker, let us not waste the time as Dr. Shrikanta has to leave early. I would like to call Dr. Sucheta Poffe madam. She is present president of IIP Dharashu branch, and she has done her UG from Ambezogai Medical College and PG from Aurangabad Government Medical College. And she is working as a consultant adolescent medicine, but she is a very dynamic and beautiful person. I know her. So let us welcome her with a big claps.
Good morning, everyone. I have been member of Solapur Academy of Pediatrics since last 15 years, and I was always enjoyed being there. And this is first time I have on this side of podium. And thank you, Dr. Kundan and Dr. Pratibha for this. And the stalwarts in the pediatric pulmonology are sitting in front of me. Still, I dare to present my topic of role of ICS in childhood asthma. I'll start with a story. I was a child with asthma. Nowadays, it is not said asthmatic because it will hamper the self-esteem of the person. So I was a child with asthma. Since childhood, I had many sleepless nights, panting and prostrations. My father used to take me to the local hospital, and he used to give me some injections, some medicine. My 3 to 4 days used to be gone. My mother and father always worried whether this attack shall not occur at the time of my examinations. And we once went to the homeopathic from Hyderabad also. He has given me all the medicines. So I'm receiver of all the pathies. Then I was once in ICU also when my friends from my undergraduate, Dr. Megha, she is my emotional strength and best critic here. She is there with me today. And they used to run me a wheel on my wheelchair in the ICU. That was the situation. And one during, I think, my PG days, or later, in my practice, I got a blue inhaler. And I thought that is the best gift anybody would have given to me. And it used to rescue my sleepless nights. And it was a bit costly at that time also, for me also. Then the story continues thereafter also. And my son, he was typically born with asthma. We consulted Dr. Pratibha also. And he has atopy, he has family history also. And we started him with pacer and inhaled corticosteroid almost for 1 to 2 years. Now he's a well-grown guy, quite tall also, nicely built, and pursuing his higher educations without any problems now. But I still suffer from many a times from asthma attacks. And that is the success story. And with this, I start my topic. Dr. Pratibha has given me a non-controversial topic. There is no any issues regarding it, but let's proceed with the theoretically. So by definition, the GINA consensus 23 definition is bronchial asthma is defined by history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, cough that vary over time and intensity together with airflow limitations. It includes all the symptomatology of asthma, and we all know it is a heterogeneous disease. Not a single etiology can be attributed for the causation of an asthma. It is characterized by chronic inflammation of the airways. To come to the diagnosis, the symptoms already are in the history, but still to cough under 5 and between 6 to 11 years. The same almost, you can read from the slides, the same are there. Cough, wheeze, difficulty in breathlessness, shortness of breath, everything is just almost same except the child may feel a tightness in the chest. He can complain 6 to 11 is a child. What GINA has advised or recommended that the diagnosis should not be solely clinical. It should be by the lung function test with the help of spirometry, and where the limited resources settings are there, you can use peak exploratory flow meter, where their guideline is more than 20% increase in the previous with usage of 2 puffs of SABA. And if there is increase, it is a likelihood of asthma. But the diagnosis can be confirmed with 4 weeks of inhaled corticosteroids if there is symptomatic improvement as well as improvement 20% in the PEF. That is how we reached the diagnosis. A diagnosis less than 5 years is a difficult one because we see all pediatricians in our daily practice. These are the patient. On the contrary, I'll say it is a bread and butter. Respiratory infections are bread and butter of every pediatrician. And it is very easy to diagnose asthma, and at least to call him as a child with asthma is very difficult in under 5. But this is a very good slide. Then here the few, not very comfortable with this. इकडे येणार नाही का थोडंसं असं घ्या कारण मला हे दिसत नाही आहे नीट हां चालेल ठीक ठीक the symptoms who are said to be very not having asthma, and some have asthma, and most of them have asthma. You can clearly see the symptoms where the wheeze is lasting less than 10 days. On the contrary, some have asthma is more than 10 days, and most of them have asthma longer for weeks together. The wheeze lingers, respiratory symptoms linger for more than 10 days. 2 to 3 episodes, and the intervening period is usually normal when we consider few have asthma. To simplify this slide, I have done this simple slide. When as it is a very big topic, we are not going to discuss it under 5 visa itself. It is a lecture, but we will consider concentrate on episodic visas and multi-trigger visas. So the pattern of wheeze is usually in days in episodic visas, while in multi-trigger visas it lingers for days to weeks. The family history and atopy usually not found in episodic. पण आपल्याकडे जेव्हा आपण विचारतो पेशंटला, सॉरी फॉर मराठी, जेव्हा विचारतो पेशंटला की तुमच्या घरात कोणाला आहे का अस्थमा, तर आमच्या पूर्ण खानदानात कोणाला अस्थमा नाही, हे नेहमीच वाक्य असतं त्यांचं. मग जेव्हा आपण थोडंसं खोदून विचारायला लागतो की तुमच्या घरी त्याच्या आईवडिलांना दम लागतो का, काही कसं औषधं घ्यावं लागतात का सारखी, तेव्हा मग कुठेतरी एखादं येतं. अँड यू कॅन फाउंड द एक्झिमा, ॲटोपी on the child, in the child. The intervening period is usually normal, and I have said that usually symptoms of varied intensity. इथे पण तोच प्रश्न येतो, नेहमी चांगला असतो, मग जेव्हा खोदून विचारलं जातं त्याला खोकला येतो का सारखा, खेळताना त्याला त्रास होतो का, रात्री कधी उठतो का दम लागला म्हणून, then they will tell you yes, all these symptoms are there. And viral illnesses, almost it is both ways, it is common, and there is no clear line of distinction between these two. So now let us come to the actual part of my talk, that is management, pharmacological and non-pharmacological. And ICS is the gold standard therapy for childhood asthma. I will be dealing only with the pharmacological management. When we say a statement like this, we have to answer why, where, what, when, all these 5H type of questions. So I have tried to solve these questions in this format. What will be the goal of management? प्रत्येकाला वाटतं की माझा पेशंट चांगलाच व्हावा. So what are we are expecting by giving the treatment? To achieve good symptom control, to minimize future risk of asthma related to mortality, the exacerbations, आपली रात्र खराब करू नये इमर्जन्सी रूममध्ये येऊन, and persistent airflow limitations. And of course, to prevent side effects of treatment. Why ICS? This is a slide. It will tell why you need ICS. It will target every pathway of inflammation. Steroids will target every pathway of inflammation. Sorry for this slide, I have taken from the YouTube, and so that's what is not clear. This is a normal bronchus, the left side, and here it is an inflamed as well as constricted bronchus. And when you give bronchodilator, it will increase it to some extent only the smooth muscle relaxations, but with constant, if you don't give steroids, only smooth muscle relaxation, constriction, contraction, and if the cycle continues for a long time, you may get a bodybuilder type of, there will be hypertrophy. But with steroids, it will return to its normal level. That's why we have answered why ICS. Why inhaled route? I was in, when we, जेव्हा माझ्या जनरेशनचे जो लोक आहेत की when we were in internship, we were doing medicine posting, and अस्थमासाठी what we used to write, tablet न बघता tablet thiophenyl 1 TDS for 30 days. So it used to be 90 days. And if you used to ask the teacher, sir थोडा लहान वाटतो हा, he is more younger than that, अर्धी 3 वेळेस देऊन टाका. That was the answer of the professor or some lecturer at that time. So they might have consumed that much of salbutamol during that time. Even during our practice, when I used to be sick, I was getting subcutaneous terbutaline at that time. That was the therapy at that. Many times I have received that injections also. That's why it is very close topic for me. And the dose, luckily this is a boon because it is a targeted drug delivery. With dose low, when you say of ICS, inhaled corticosteroid, is just 200 micrograms. When the dose is high, 2 milligram is 2,000 micrograms. Even the prednisolone tablet is 4 milligram. And look at the site of action. We all know the serious side effects of oral steroid, and we cannot dare to give it on the longer term basis. So second, we have answered the question why. Now, how ICS are used? There are some terms given in the GINA. My entire topic is based on GINA 23 guidelines. This is maintenance therapy prescribed for regular basis, and second is the controller. Controller means which targets the both domains of asthma, that is control as well as future risk of asthma. There is overlapping between maintenance and controller therapy. And third is reliever, taken as needed for quick relief, that is rescue, AIR, or anti-inflammatory reliever. This is ICS per formoterol. Usually it is preferably formoterol is AIR, anti-inflammatory reliever, because it has a long acting, but with rapid action of LABA. And finally is a MART. We have to get acquainted with these terms. MART, maintenance as well as reliever. Here the low dose inhaled corticosteroid plus formoterol, that is same for the maintenance as well as a reliever. This is no longer used, but still I took this slide because Gina does not say the mild asthma, because patients may think that they have mild asthma and they will not adhere to their inhaled corticosteroids, and they may land into the exacerbations or bad symptoms. That's why they do not recommend the term mild asthma. But still, it is these are I am not going to detail into, we can just read the slides, and it all based on daytime symptoms, 2 times per week or more, and depending on daily symptoms, nighttime symptoms, how many times the child wakes up, and peak flow while examination, peak flowmetry. So 80%, and between 60 to 80% is the reduction. So here is a slide, beautiful slide. I request everyone to have the slide in their OPD, because every time if you look at the slide, then only you can easily memorize. There is no need to always go back to it is a good slide to go back and see. For every treatment modality, they have given the same cycle: review, assess, and adjust. And it is given: assess the patient in the form that exclude alternative diagnosis, symptom control, and modifiable risk factors if there are any. Then comorbidities like allergic rhinitis. What are the inhaler techniques if we are already on the inhalers, whether they are adhering to the treatment, and caregiver preferences and goals, that is patient's goals. And then adjust the dose, adjust the treatment, treat modifiable risk factors. We can read all that, no need to read that part. And review, whenever the patient again comes to you, look at the exacerbation, symptom control, and any side effects, and whether we are able to rule out decrease the comorbidities also. So step 1 is preferred controller choice, and here is the other controller options. Preferred controller choice is based on population studies, on this evidence-based studies and meta-analysis. That's why Gina prefers this preferred controller choice. And the second one is, if at all, if this is not possible due to many causes, like patient's his choices or his conditions, affordability, then this is the second option. And relievers are whenever needed as to relieve of the acute symptoms. So step 1 in the when to use below 5 years. I will take 2 case scenarios from Dr. Shrikant's video, one of the videos. A 4-year child comes in the emergency room at night with severe breathlessness and hypoxia, less than 92. And the child had suffered only once previously, 1 year back. Still, it was not an emergency admission. He just had breathlessness. But now he came with severe attack. And the second case, every 3 to 4 weeks, the child comes in OPD, says that I have breathlessness. The mother complains that he has breathlessness, he has some symptoms, respiratory symptoms. And every time he's cured of some medications by the doctor, like oral medications. And he feels better. Sometimes he takes nebulization. And these are the 2 scenarios. So we determine whether to give ICS on severity as well as frequency with which the child suffers. So step 1 is the insufficient evidence to start daily inhaled corticosteroids. Controllers are always inhaled corticosteroids. So take it as granted that for daily controller means they are inhaled corticosteroids. But if the child, step 2, when the child has symptoms more than 2 times in a week, then we can think of starting daily low dose inhaled corticosteroid. Low dose means 100 microgram twice a day. But if the patient, the other control or options which are limited indications or less evidence, inferior to the preferred one, are leukotriene LTRA and short course of ICS at the onset of respiratory illness. This is the inferior options. And reliever in all cases is needed short acting beta agonist with spacer and MDI. Spacer and MDI always consider this, not nebulizers. But nebulizers are a reality and spacers and MDI are a fantasy for us. Third is double the dose. That is what we were prescribing in step 2. We had to increase the dose. And here the inferior option is low dose ICS plus, again, LTRA, that is our Montelukast. But from 3, if we are doubling the dose, I want to remind is, doubling the dose, it will just add a little benefit clinically, but it will start increasing the side effects. And if we go into a higher dose of steroids, even the side effects will be more, but the clinical benefits may not be. So low dose steroids are the preferred modality. And when the step 4, refer to these two, because we are not going to deal with the step 4. But you can read, but this needs evaluation. So clear when to use below 5 years? Sorry, this is the oldest slide. I should have taken from the GINA only 23. When to use in 6 to 11 years. There is little difference. And they have classified the symptoms less than twice a month. That is a step 1. Less than twice a month. Here, again the preferred controller instead of other controller options, the recent guidelines still says that low dose ICS taken whenever SABA is taken. Means once the patient is symptomatic, he wants to get relief of his symptoms, he will take a SABA inhaler, and after that few minutes he will take a inhaled corticosteroids. That is the step 1 treatment, that is a preferred controller, because there is no need to continue, put the patient on maintenance therapy in this one. But once the patient has symptoms twice a month more or less than daily, but more than twice a month, then the child will definitely need daily low dose of steroids, inhaled corticosteroids. And again the second inferior option is leukotriene inhibitors or daily low dose ICS and SOS SABA. But please be comfortable with the preferred controller only, because this is an inferior option. And that step 3, low dose ICS with LABA. LABA is preferably used after 4 years. The two in the market are formoterol and salmeterol. That's what I know. I have not seen any other formulation in the market. The low dose ICS plus LABA, or we have to increase the dose from low dose to medium dose. But Dr. Srikanth, I think it is on the patients, this or just, they have recommended twice. So I'm not also very clear. Please explain me it later. Because medium dose increase or this, which out of this, which we have to choose? Does it depend on the patient or something else?
The medium dose ICS causes more
Side effects.
So because you always want to keep your ICS lower, low dose.
Okay.
So it's always better to go with low dose ICS and LABA rather than medium dose or high dose ICS.
So this is also clear.
That is very clear,
Okay.
and there are studies supporting low dose ICS plus LABA, low dose ICS plus LTRA, and doubling the dose of steroid. Low dose ICS LABA has much more benefit compared to those two of them.
So it is a clear-cut message that low dose LABA plus, low dose ICS plus LABA is the drug of choice, even in 6 to 11 years of age. And when this is red mark, step 4 and step 5, here we should be very cautious increasing.
Definition, low, medium, high dose.
That will come in next slide. That will come in the next slide, and I'll tell you. So that this step 4 and step 5, so this is red mark. We have to be very cautious in dealing with such patients. If you are very comfortable, you are well aware, you have all the modalities, investigation modalities, then only handle this type of patients or refer them to the specialist. Because we are not going to go from the high dose of steroids in our practice. And when to use in 12 years and above, it's all, and from step 1 to step 5, it is low dose steroids plus LABA. Everywhere it is from step 1 and step 2, step 3, step 4, up to step 3, it is low dose where we are going to manage in our OPD practice. Step 3, low dose steroids plus LABA. That is, here it is called as MARD, maintenance as well as reliever therapy. The child will take a single dose of his normal maintenance dose, and if he is symptomatic, he may take the another dose of his ICS plus LABA as a reliever also. So the track to here is inferior one, but the preferred one is the upper track. And here in the second track, ICS, and whenever needed, SABA. Again, we have seen, he has said ki ICS plus only, and whenever needed, SABA. Because if you take large doses of SABA also, that is short-acting beta agonist, there are still side effects associated. And one adult study has found that if you are using more than 12 canisters per year, the death has been reported. So it is better to stick to the previous guidelines. Only in our cases, only it will be an affordability issue. Otherwise, there is no much need to go to the inferior option. Again, same low dose with maintenance ICS. So everything it is in first ICS with LABA, and in second option, which is inferior option, it is a low dose maintenance ICS only. And step 4 and step 5, again we are very cautious with dealing with such patients. Dose, Dr. Hambire, the dose we are talking, better to have it as in our OPD, because it is not, when we are not routinely using it, you may forget the dose, so better to have a chart in your OPD. Only 100 to 200 microgram is a low dose, and 200 to 400 is a medium, and more than 600 is high dose related to Budocort. That is stepping up and stepping down. No.
So when you start, so for again, for less than 5 years, 6 to 11 years, more than 12 years, there are specified doses for each age group. For less than 5 years, it's up to 200 micrograms, low dose. Here, 6 to 11 years, 400. And for 12 and above, you can go up to 800 as low dose.
Yes.
So more than 12 years, 800 is considered as low dose. But for your question, when you start, you can start 200 twice a day, even in a 2-year-old or a 3-year-old. In 1 month, you reduce it to once a day. That is once in the morning, once in the night time. The only thing is, when you are starting, low dose ICS and LABA. So you have to be very, very specific in what you're doing, because what people write is 100 micrograms of budesonide and formoterol, or fluticasone and formoterol, 2 puffs twice a day. That is wrong, because what you're doing is you're not only doubling the dose of steroid, you're also doubling the dose of LABA. So 6 and 6 of is causing more side effects. And because it goes and attaches to the receptors, LABA also goes and acts on SABA receptors only. Because it avidly attaches to the receptor, that causes SABA not to work in acute exacerbations. And that leads to a lot of side effects. So always stick to lowest possible dose of LABA. So 200 of budesonide plus 6 of LABA is what is recommended and what should be used. Just because somebody tells you use 100 micrograms of budesonide and 6 micrograms of formoterol 2 times a day, that will be better. 2 puffs 2 twice a day, that is not better.
Okay, thank you. And the dose is also depends upon the patient's respiratory capability also. So it is 110 kg weight child will take the dose, is it 100, if we prescribe 100 microgram, that may be different for the child only, because of depending on his respiratory capacity also. So till now we have come to the question, what ways? Only 3 ways are there: pressurized meter dose with spacers, dry powder inhalers, and nebulizers. The preferred one are in the pressurized meter dose has propellant, only small amount of drug and some surfactant. Propellant acts as a fuel to deliver drug into the respiratory system. But the first part is impaction, and then it will go to the smaller particles will go to lower airway, means where we want our action to be there. That is the airways, larger airways, and thus we have to shake it. That is a must. And the child has to hold the breath, or anyone has to hold the breath to get the particles into the airways. But if it's coordination is not possible, then we have to use the spacer. And nebulizers will give aerosol particles of different shapes and size that have high impaction on the upper airways. That's why we say when we have a croup patient, we ask them to nebulize with the adrenaline solution only. So we don't recommend the inhalation in patients of croup. And third one are dry powder inhalator. The mechanism is not like this, MDI, pressurized MDI. It is a different one. And the breath accentuation has to be there. The patient should have good inspiratory efforts to take maximum benefits of this DPIs. So how you choose device? This is a bit complicated slide. Let's see. And it is also practice, individualized practice, how your patient is cooperating with you, how the caretakers are cooperating. Many a times I find that if I prescribe even the MDI to 8 to 10 year old, even after so many times explaining properly, he will hold in his mouth only. He will not deeply inhale the drug, and that is useless also. So age group, it has less than 4 years MDI with spacer and mask, that is properly fitting. But children tend to shake their head while giving, that is also an issue. More than 4 years, it is MDI with spacer, mouthpiece only. And more than 6 years also MDI spacer. But if the child there are many issues, developmental in subnormal child or spastic child, then still you have to use spacers also. The percentage of drug deposition using various devices, and the green one is lung, and you can see which is maximum is MDI with spacer and DPI. Here the maximum deposition, while in nebulizer it is a upper airways deposition, oropharyngeal deposition, and with spacer it is MDI with spacer, the apparatus deposition is more. Nowadays all the spacers are zero static spacers, so they have reduced that, and the exhaled is more in the nebulizer. So got it that MDI and spacers are superior in less than 6 to 8 years. Let's discuss some cases. Why we are not succeeding in our goal of proper treatment, asthma control. See, let's take a 12-year child with asthma. Symptoms vary frequently. He gets relief with nebulization with salbutamol and budesonide as when needed. He was hospitalized once and has frequent school absentees. So what went wrong? On whose part it went wrong? It is all, I think it is clinician's part to convince the patient that he has asthma. And what should be the strategy? As well said, he is an adolescent. They are very resistant. I am doing this last year. They don't accept that they have a disease, and they feel that they don't want to get stigma of any disease. They are very reluctant to use any type of medications for long term. But once you convince them, becomes easy. So what should be the strategy? He needs low dose inhaled corticosteroid plus LABA. The second case, 8-year-old diagnosed as asthma, prescribed with ICS, taken for 3 months, and discontinued as he felt better. Came with exacerbations at midnight. Again, there was no proper tapering of the dose. He was not counseled that it should be done in a systematic way. And that should be our strategy, and it is our responsibility to counsel the patient and their relatives. This is a case 3, 14-year-old diagnosed as asthma on ICS and LABA. He has good controls, stopped as affordability issue. And I have experienced this because they do not afford the ICS plus LABA that is commonly used for Accord. That is a bit higher in price. What went wrong? The situation is wrong here. We cannot do anything much here. Fourth case, 5-year-old child of a non-allopathic consultant, diagnosed as multi-trigger wheezer, started on low-dose ICS as maintenance dose, stopped and shifted to some immunity boosters, Ayurvedic treatment. So what went wrong and what can be strategy? What went wrong is he came to you as a consultant, and what can be done? When he comes in the emergency room, switch off the phone, don't answer him, let him go to our next friend, and next time refer to these consultants, to next morning refer to someone else, they can handle better. Last case 5 is a 10 years old, prescribed with ICS, no improvement. So he was added LABA, still no improvement. Again, after every 2 weeks, 2 to 3 weeks, we started going LTRA. The child is still symptomatic. What went wrong? What may the possibility? This went wrong. So every time, the technique was like this. Not exactly like this, but the techniques were wrong. So every time, again, this is a beautiful slide. See, assess, adjust, and review. These, every time when the patient comes to you, go in this the same manner, then the patient will be happy and you will be satisfied. And I have written thank you because this is last slide. Thank you.
Madam, one question. Is there any role of Montelukast and Bambuterol combination, that is, pharma is bombarding for too many times? Actual role, if any?
It's a falsified combination. So first of all, Montelukast itself is not a great drug. It is not an anti-inflammatory. It is just a leukotriene receptor antagonist, and leukotriene receptor antagonist is only added as an add-on medication. It is never a first-line medication. See, when we do general pediatrics, spending 15 minutes, 20 minutes, 30 minutes to counsel a patient is that much more a difficult job. And after that, another 100 questions from them is going to take more time of yours rather than actually doing the justice. That is where long leukotriene receptor antagonists are so used and misused also.
Initially, it was thought that Montelukast had very few side effects, but now it has surfacing that sleep disturbances as well as behavioral. Sleep disturbances and behavioral problem are surfing up with Montelukast, continuous use of Montelukast also.
So Montelukast is only used when you have a child who is on budesonide, where you are not in a position to start LABA, say between 2 to 4 years. Do you want to start LABA? Yes, there is a lot of recommendations now and a lot of studies saying can use even formoterol, but we try to hold ourselves back on formoterol. But salmeterol, more than 2 years in, particularly you get those difficult to treat viral induced wheezers. A child comes to you every 15 days or 20 days with viral infection and wheezes with it. You tried budesonide, it doesn't work. You tried Montelukast with it doesn't work. In them, low dose fluticasone with salmeterol does a wonderful job, because pathophysiology is different there. They're not like your normal eosinophilic wheezers. They're not like your IG-based wheezers. They have more of neutrophilic inflammation. In those children, having LABA adds more advantage. But in a child who has come to you, who has wheezing, but also has mild intermittent AR symptoms, there adding Montelukast, not for 5 days, not for 7 days, but at least for minimum of 3 months. So definitely warrants. Definitely works.
In allergic rhinitis also Montelukast works.
Absolutely no.
Thank you.
Thank you, Dr. Sucheta. It has been a wonderful lecture. Since 2008 or 9, I have been moving as a faculty for various state and national conferences. But I can say these slides were very authentic and scientific. आणि तुम्ही खूप छान पद्धतीने एक्सप्लेन केला. आम्हालाही बरंच काही कळलं बरं त्याच्यातलं. व्हेरी नाईस. थँक्यू व्हेरी मच. अँड नाव खूप छान ताळी वाजायला पाहिजे ना ॲक्च्युली. येस. थँक्यू मॅडम. Now I call upon our dynamic president, Dr. Kundan Chopre, for presenting next lecture. He has done his UG from GMC, Grand Medical College, and PG from Caslial Medical Institute, and he has worked as an organizing secretary for Maha Pedicon, and now he is a present president of Solapur IAP. I welcome you.
Good morning all. First of all, I was only in the team, not as a player, but I was forced to play match. I want to be in the shoes of my lecturer, teacher, HOD, Dr. Vaidya sir. He is not able to come here. And this topic is very important, so I have been taken this topic. I have, as a substitute, they think me as an impact player, but I will try to do my best. Today's topic is expert opinion on newer approaches and emerging trends in mucus management. What is airway mucus? It is secreted by goblet cell. It is lungs' native immune system. It traps particulates and microorganisms, and it causes subsequent clearance by ciliary transport that eventually leads to cough. The changes in rheologic properties of mucus, mucociliary clearance defects, ineffective cough reflex mechanism, these all contribute to infection and inflammation. This causes airway obstruction, and ultimately parenchymal damage happens. The mucus hypersecretion plays an important role and is an important pathophysiological and clinical manifestation in acute bronchiolitis. Then what are the treatment options for airway mucus clearance? These are two ways. The first is airway clearance therapy, and second is pharmacological, that is mucoactive agents. Airway clearance, we know there are various breathing techniques, atogenic drainage, and mechanical devices like suctions. Pharmacological or mucoactive agents like mucokinetics, what we are using, bronchodilators and ambroxols. Then mucolytics like N-acetylcysteine, Dornase alpha. Then mucoregulators like carbamazepine and macrolides. And the most important is, today's topic of discussion is expectorants, that is hypertonic saline. Then what is hypertonic saline? The hypertonic saline is concentrated sterile solution of sodium chloride in water. The concentration of sodium NaCl is greater than that of physiological saline or normal saline, that is 0.9%, which is normal saline. Then various mechanisms are proposed for hypertonic saline. The predominant one is that it decreases the viscoelasticity of the airway secretion better to ease the clearance from airway. It breaks the ionic bonds within the mucus gel, and it increases the depth of the airway surface liquid layer. Other modes of action proposed are, it disrupts the structure of mucus gel, it stimulates the movement of cilia, it causes sputum induction and cough, which helps to clear sputum outside the bronchi and thus improves airway obstruction, and it absorbs water from the mucosa and submucosa, and it reduces the edema of the airway wall. Thus, the flow property is made more favorable and thereby improves mucus clearance. Then, what is the clinical efficacy of nebulized hypertonic saline? Now, the world is of evidence-based medicine, so everybody wants evidence. If one is proposing why it is useful, these are the various studies. This is taken from Cochrane Library, that is nebulized hypertonic saline solution for acute bronchiolitis in infants. The systematic review is of 11 randomized controlled trial involving almost 1,000 infants with mild to moderate acute viral bronchiolitis. The children up to 24 months of age diagnosed with acute bronchiolitis are taken into the study. The study includes various combinations like nebulized 3% hypertonic saline alone versus nebulized 0.9% saline, then nebulized 3% hypertonic saline plus bronchodilator versus nebulized 0.9% saline, then nebulized 3% hypertonic saline plus bronchodilator versus nebulized 0.9% saline plus same bronchodilator, and then nebulized 3% hypertonic saline alone or plus bronchodilator versus standard treatment. Then, these are the key outcomes. The most important, what patient asks us, length of the hospital stay. The nebulized 3% saline has statistically significant shorter mean length of hospital stay. This is almost less than 0.1 to 1.5, that is 1 to 2 days. It represents almost 20% reduction in the hospital stay, and the p-value is very significant. It is less than 0.001. Then second key outcome was the clinically severity scores. The lower mean clinical severity score post-treatment in the nebulized hypertonic saline was noted. And the time for resolution of symptoms and signs. Shorter duration of respiratory signs and symptoms with 3% nebulized solution were noted. The p-value is here is also very significant. P is not 1. The adverse event, the most of the time there is no significant adverse events were reported with hypertonic saline. And the conclusion of the study was, nebulized 3% hypertonic saline may significantly reduce the length of hospital stay among infants with hospitalized with non-severe acute bronchiolitis, and it improves the clinical severity score in both outpatient and inpatient population. Thus, the nebulized 3% hypertonic saline used in conjunction with the bronchodilator should be considered as effective and safe treatment for infants with mild to moderate acute viral bronchiolitis. Then there is another study done at India only. This is done by Harish Gupta and Vivek Gupta. This shows the effectiveness of 3% hypertonic saline nebulization in acute bronchiolitis among Indian children. The study contains almost 100 hospitalized children with acute bronchiolitis between the age of 2 months to 24 months. The treatment groups were Group A was nebulized 3% hypertonic saline, 4 ml was used. Group B was nebulized 0.9% normal saline, and Group C was nebulized salbutamol in a dose of 0.15 milligram per kg body weight in normal saline to make total volume of 4 ml using an oxygen flow rate of 8 liter per minute. The key outcome, most important, clinical severity score, there is significant reduction in clinical severity score in 3% hypertonic saline. Then the length of hospital stay, reduction in length of hospital stay with 3% hypertonic saline. Thus the conclusion is nebulized 3% hypertonic saline without additional bronchodilators is an effective and safe treatment for non-asthmatic, moderately ill patients with acute bronchiolitis in terms of reducing the clinical severity score and length of hospital stay as compared to 0.9% saline and salbutamol in 0.9% saline. Then there is most of the time we have to induct the sputum. There is use of hypertonic saline in sputum induction also. This is the most simple, cost-effective and non-invasive, safe procedure to collect respiratory secretions for lung airway for diagnosis of various respiratory diseases. The mechanism that it increases the osmolarity of airway lining fluid, it increases the vascular permeability in the bronchial mucosa, and it induces production of mucus by submucosal glands. Thus, the concentration of hypertonic saline used for this sputum induction is 0.9 to 7% with duration of nebulization mostly 15 to 20 minutes. Ultrasonic nebulizers are recommended for this procedure. And there is pre-treatment with bronchodilator, that is salbutamol 2 to 4 puffs from MDI is recommended to prevent excessive bronchoconstriction. Then what are the guidelines? These are the various guidelines. This is ERS guideline, that is European Respiratory Society of Nebulization, shows that the nebulization with hypertonic saline solutions are reportedly more effective than normal saline in inducing sputum. Then these are the CDC guidelines, that is Center for Disease Control and Prevention, that mention that patients unable to cough up sputum, deep sputum producing coughing may be induced by inhalation of aerosol of warm sterile hypertonic saline. Then NICE guideline, that is National Institute of Health and Care Excellence, it advises that the key feature of sputum induction is inhalation of nebulized hypertonic saline. And this NSW guideline, that is New South Wales Health Association, recommends that patients should be nebulized with 3% hypertonic saline solution for expectoration of respiratory secretion at diagnostic purpose. Then what is the safety? It is safe and well tolerated in patients with bronchiolitis, bronchiectasis and cystic fibrosis in the clinical studies. And there is no significant adverse event were reported when used with any indication. This is commonly reported side effect is only exacerbation of cough and bronchospasm. That is very mild and it is resolved spontaneously. Thank you. Before asking question, I will tell one story. When Einstein got the Nobel Prize, he used to go travel various lectures, and his driver was accompanying him in various lectures. The driver said that you are taking the same lecture everywhere and you are getting good response. What a big deal. So Einstein said, you take the lecture for today's lecture, and I will just sit in the audience. So he sit in the audience. At that time, there were no social media, so nobody recognized who is the Einstein. The driver has taken the good lecture, and followed by, they started asking question. At that time, driver got very confused. So he thought this lecture taking is very easy, but asking question is very difficult. So he said, the question is good, but I think my driver will answer better than me. So he directed this question to his driver, the Einstein. I'm not as genius as speaker, but I am smart, street smart like his driver. I will direct my question to Srikanta sir. Yeah, ma'am.
Thank you, Dr. Kundan. Really smart work, because he knows it after 11 o'clock at night he has to take this lecture, and smartly prepared, very nicely explained actually. 3% NS is very useful, it's very safe. It comes as like आता तरी अगदी safe ह्याच्यामध्ये येतो ampoule hypertonic saline is really helpful, because we all have faced since last 2-3 months viral bronchiolitis. That way it is very useful. 3% NS we have to use it. Now it is the same only, it's in ampoule. We shouldn't combine actually, we never combine, but we can use it as a normal saline combination with adenine. Can we use, no?
Yeah.
Now we will inaugurate this function officially as lot of doctors have come now. I'll welcome President only again to inauguration. सगळ्यांना तुम्ही कॉल करा.
श्रीकांत सर मॅच बॉक्स आहे कमी आहे. संदीप सर, महेश आरकाल, मेरू मॅडम. प्रतिभा मॅडम, यू ऑल्सो. करवा सर. हां, अतुल कुलकर्णी सर. कासलेवाल सर. आशुतोष आणि संदीप.
दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम्.
तालियों से एंथुजियाज्म बढ़ता है तो तालियां बजाते रहे. राइट? यस, इट्स अ सच अ वंडरफुल एकेडमिक्स टुडे. तो तालियां तो बजना चाहिए. यस. नाउ आई कॉल अपॉन Now for the next lecture, I invite Dr. Shrikanta JT. Even though he is very 10 to 15 years younger than me or any of us, but knowledge is very, very high. He is an interventional pulmonologist. हे concept आहे ना, interventional pulmonologist. आपण फक्त ऐकलेलं असतो की interventional cardiologist है ना. तर आता हे नवीन आहे की interventional pulmonologist, that too in a pediatrics. It's very difficult. आपल्याला वेनफ्लो लावायला स्किल लागतो, ब्रॉन्कोस्कोप टी घालायला स्किल लागतो. त्याच्या आत जाऊन काय इंटरव्हेन्शन करतात हेही मी खूप वाटत नव्हतं. आज फर्स्ट टाईम आय मेट हिम ॲक्च्युली. वी हॅव बीन अ को फॅकल्टी इन महापेडिकॉन इन ऑनलाईन जेव्हा झालं होतं. फक्त एवढं व्हिडिओ बघितले, आय वॉज सो इम्प्रेस की अरे इनको कभी तो सोलापूर बुलाना चाहिए है ना. सो वेन आय थॉट वेन ही केम, मी कुठलंही लेक्चर ॲक्सेप्ट केलं. मी म्हटले शांत बसून शिकणार आहे की काय होते. होप वन डे ॲटलीस्ट आय कॅन डू 10% ऑफ हिज वर्क. Right? So he is an interventional pediatric pulmonologist working at Bangalore. He has done his clinical fellow in pediatric pulmonology from Singapore and also for interventional bronchoscopy from Ancona, Italy. He is expert in everything, so much of a list. We can see the videos. Fiber optic bronchoscopy especially with the BAL, bronchoscopic biopsy and so many things. Asthma also. He is presenting excellent real case based videos solving difficult cases. Whenever I face difficulty ना ब्रॉन्कोस्कोपी काहीतरी दिसल्यासारखं वाटतं पण काय कळत नाही, तेव्हा मी त्यांना फोन करते की काय असेल ते आता. सो ही सॉल्व सो मेनी केसेस. लेट्स वेलकम विथ बहुत जोर की तालियों से हो जाए. यस.
प्रेजेंटेशन ओपन किया था ना, क्लोज किया गया. Right. I personally thank Solapur Association of Pediatrics, IAP Solapur, for inviting me and having me here. I personally thank Dr. Kundan, who has been really helpful in getting me here safely, and Dr. Pratibha Patil for always being a constant support and supporting with me with all our cases, and more importantly, calling me here. So, see, Madam just shared a story why ICS helps in asthma. So my story of becoming an interventional pulmonologist stemmed from criticism. So what was the criticism? We had a cardiothoracic surgeon in Singapore. So he would come to us and he would say, what do you guys do? Pediatric pulmonologists, what do you guys do? You give antibiotics, you give steroids, you give nebulizations. Apart from that, if you do not know, you just put a scope inside and see what is happening. Apart from that, you don't do anything. That is where this concept of interventional pulmonology started, and more importantly, that was the driving force for me. Because until unless somebody doesn't taunt you, so I did not take the taunting in a bad way. I took the taunting in a reasonable way. Until unless somebody criticizes you, you'll never go back and look at it as a problem. You will always look at it as a criticism only. So when I started looking at it, I started realizing, yes, there are so many things that should be done and that can be done. That is what took me through this journey of last 12 years of learning and more importantly, taking it forward as what it comes. So we in our center do a lot of interventions. So interventions can be from simple flexible bronchoscopies to the highest level of interventions. So what I'm going to show is a snippet of everything that we do. And this snippet is going to involve only a didactic, not only didactic lectures, it has a lot of vivid videos. So as everybody says, a single photo can share 1,000 memories, a single video can share 1,000,000 memories. So for people who have been sending or referring foreign bodies, this has been the foreign body retrieval for ages. So this is a normal flexible bronchoscope if people have been accustomed to using one or have been seen using one. So this is a normal flexible bronchoscope. So you can see there's a nice, this was when Shigito Hikeda, the Japanese pulmonologist who first did a fiber optic bronchoscope which can be seen through lens. So this is how it would look, and this is what the vision was. And this is how we even now do flexible bronchoscopies in children. But you cannot retrieve all the foreign bodies through flexible bronchoscopies. Yes, we do a lot of flexible foreign body retrieval, but there are a few foreign bodies which are too big in size or which are too friable where you require a rigid bronchoscope. So this is a rigid bronchoscopy sweat, and this is the rigid bronchoscopic retrieval instruments. So I'm just going to present a few cases. A 4-year-old school-going child, accidental foreign body injection, evaluated in his hometown with chest X-ray and CT, and was told to be normal with no evidence of foreign bodies. As the child was making this sound, parents came to us. So I would just want you to listen to this sound. Volume. So probably you can hear this sound. So this was the sound this child was currently. Very good. So we knew there was something wrong. Why would a child present this inspiratory stridor sound? So we went in, and this was the site of the foreign body which was misdiagnosed as having nothing. So we went ahead and we retrieved the foreign body, but this was a way that has been utilized from 1897. So you go inside, you see the foreign body, you try to retrieve it through a flexible bronchoscope, it doesn't come out, you put in a rigid bronchoscope, you hold it with a flexible forceps, you retrieve it. It hardly takes around, say, 2 minutes, 3 minutes of our job. The only thing is sedation, paralysis, OT, all those things takes a little bit longer time. So foreign body is out, child is perfectly fine, and there's no granulation tissue, nothing to be worried about. So this is what has been done for ages. So for last 130 years, this has been done. So what we are currently doing is something called as foreign body, the new way or the cold way. So in Bangalore, there are adolescents who are drinking, and in one particular party like that had accidental foreign body injection, was evaluated, again chest x-ray and treated with oral antibiotics for 7 days. Because he continued to have, he was referred to us. So this was his CT when we got it done. So what you can see is there's a nice foreign body there with a bronchial cutoff sign. So this is the site of foreign body, and there was left lower lobe complete collapse. So you go inside the airway, this was the site of obstruction. Left side is completely normal. So this was a beetle nut. So then he was able to tell us that this is a beetle nut. So what I'm using here is I'm using something called as cryoprobe, which you can see ice frosting there. So we use cryoprobe where the gas, which is carbon dioxide, goes through a nozzle, and through Joule-Thomson effect, when a liquid goes through a very, very tiny space, because of the effect, it turns into gas, and that carbon dioxide gas freezes to minus 97 degrees here, holds the foreign body in total. So when we have peanuts, so if there are pediatric surgeons around or ENT surgeons around, you try retrieving a foreign body from the airways, it just keeps breaking in. Keeps breaking into small pieces, and it just gets lodged into the airways. Pediatric surgeons do not have the liberty of having a flexible bronchoscope, and because they do not have a liberty of using a flexible bronchoscope, the small bits and pieces are left behind, and they are the ones which come back to you in future as idiopathic bronchiectasis. They do not come out. It's a myth that these small foreign body pieces will be coughed out by children. These small peanut pieces are so, they call it as gigatrite. It is as sticky as it is. It goes inside, gets stuck, causes bronchiectasis, and in future you'll be just treating it as idiopathic bronchiectasis. And if you take a history, you'll always see that this particular child has had a history of foreign body in the past. So this is how we do it. So we go in, we hold the foreign body in total. So if I had done this with a flexible or a rigid forceps, this would have taken me at least 2 to 3 hours. By here, the whole foreign body comes out in total. I can see the foreign body coming out in total rather than just in piecemeal. And more importantly, as soon as I take the foreign body out, you can see so much of pus. And beetle nut, being beetle nut, causes significant bronchostenosis. It has to be removed within a day maximum. Even if within a day it is not removed, it can cause significant amount of bronchostenosis. And we have seen a lot of children coming with significant bronchostenosis. So again, a lot of places where I go, whenever I deliberate a lecture on anything in and around interventional pulmonology, so I always say, so wherever pediatrician stops thinking, we always start thinking. because there is a way that we can do, and there is a way that we can always think about. It's a 14-year-old adolescent with history of road traffic accident with traumatic head injury and significant facial injury. Required endotracheal intubation followed by tracheostomy for prolonged ventilation. That probably a lot of here would have seen. Decannulation after 1 month, 2 months post decannulation, developed cough, exertional dyspnea and stridor. So you know that we are going towards a severe subglottic stenosis, isn't it? So this was the child. You can see this is after everything. So you can see how difficult we were. So surgeon everywhere had surgery on the jaws, had surgeries on the mandible. This was the only amount of oral opening of this boy. With this, we were able to do all the procedures that we did. So initially, we have a discussion with the parents. We tell them that bronchoscopic intervention suffices in at least 70 to 80% of the patients. So what we do is we go inside the airway. So this did not have a treatment, or this did not have a therapy, that is non-surgical therapy. This is a bronchoscopic therapy. So what we are doing is we are taking an electrocautery cut. This is an electrocautery knife, and this is a Mercedes-Benz sign that I am using. So after using a Mercedes-Benz sign cut, we go in and we serially dilate the airway with something called as CRE balloons. These are called as CRE balloons. So where I was not even able to pass a 3 mm bronchoscope, I am not only able to pass a 3 mm bronchoscope comfortably, I am able to completely recanalize the lumen. So this boy came with severe stridor, went back home with 0 stridor. So this was the airway. So you can see this is a rigid bronchoscope which is almost 11 barrel. 11 barrel means 14 millimeter in diameter. So 14 millimeter barrel is able to go through a nice airway. But the only thing is, when we have complex stenosis like this, we also tell them that there is a chance of restenosis. And this boy came back with a restenosis. What we did was we repeated the same procedure, but we also went ahead and stented the boy. So this is the stent that we put. We have multiple stents that we can put. This is called as a silicone stent. So silicone stent helps in keeping the airway patent. Silicone stent helps in making the highway so that there is no chances of restenosis, and more importantly makes the child comfortable without having any complications. This was 3 months post stenting. So you can see the stent sitting quite nicely inside the airway. Little bit of secretions, but otherwise absolutely normal. Airways are perfectly fine. So if and only if any child has critical tracheal stenosis, what would we do? We would just tell them use tracheostomy as long as possible. We'll see what happens later. Or we send them to surgeons. Surgery has significant morbidity. It is not as simple as it looks. It is not at all as simple as it sounds. And there is almost 50-50 chances of restenosis. So this is an alternative approach. So we not only use silicone stents, we also use something called as ELA stents, which are self-absorbable BD stents. So particularly when we get children with bronchomalicias, you would have seen neonates, bronchomalacia, not able to extubate at all, difficulty in extubation. We just put that stent, it gets absorbed within 4 to 6 weeks. Child is extubated, child is ready to go home. Complex cardiac surgeries. Child has complex cardiac anomalies, you do surgeries for them. Child is stuck on ventilator, you do a tracheostomy and send them home with BiPAP or whatever non-invasive therapy you are. So we just go ahead, we put a ELA stent and child is ready to go home without having any interventions. So this was almost stent removal. So you can see the airway is completely patent. The airway, which was almost 2 to 3 millimeter in diameter, is now completely open. So conditions requiring balloon tracheoplasty plus or minus stent is congenital tracheal stenosis, post-intubation tracheal stenosis, and post-tracheostomy tracheal stenosis. These are the most commonest causes that we come across. And with the advent of newer endotracheal tubes and good practices of endotracheal intubation, this has come down definitely, but we do see at least 1 case a month in our center. So bronchial stenosis is also something that we see. This was betel nut ingestion, so presented to us, and this was his after betel nut removal. This was his airway. So that's right upper lobe bronchus, right bronchus intermedius. I'm able to pass a guide wire, but there's very difficulty in passing a bronchoscope. So I'm going through, we always do it under utmost safety. We have everything in our center. This is a C-arm, and through C-arm we are passing under the C-arm vision we are passing a CRE balloon and we are dilating. And once we balloon dilate, which was completely occluded is now patent. So this not only prevents a child from getting a future episode of bronchiectasis, but also makes sure that they live comfortably as long as they live. So this is your bronchostenosis, and bronchostenosis with significant malicias, we also stent those airways. So that is your tracheal anomalies. Pediatric airway tumors are very common. If somebody has dealt with pediatric airways, they can always tell you that yes, pediatric airway tumors are very common. It is not that very uncommon, and we have seen from leiomyomas to lipomas to mucoepidermoid carcinomas to carcinoma tumors. We have seen everything. So this is a 13-year-old adolescent presented with high-grade fever, cough and breathlessness for 3 days. Admitted 2 months back with similar complaints, no history of wheeze or atopy. On examination, signs suggestive of left lower lobe consolidation. So this was the first X-ray, completely better. Second X-ray. So whenever you have recurrent pneumonia, same-sided pneumonias, first thing we get to know is foreign body. So if there is no foreign body, we start talking about primary immunodeficiencies, we start talking about other possibilities of a possible same-sided pneumonia, or probably even a congenital airway anomaly like CPAM or sequestration, which is just sitting there and causing this particular thing to happen. But for our So this was the CT of the child. This was the cutoff sign. We went inside, we saw this huge tumor-like lesion. Huge tumor-like lesion. So always before even we go in, we take biopsy from the lesion to make sure what we are dealing there with. This turned out to be a typical carcinoma tumor. So when there is a typical carcinoma tumor, chances of a bronchoscopic resection alone is more than enough. If it is a atypical carcinoma tumor, child requires not lobectomy, child requires a pneumonectomy here. So because atypical carcinoma tumor is going to progress, this would have required a pneumonectomy with lifelong scoliosis, kyphosis, and a lot of other complications. So once we had a typical carcinoma tumor, we sat down with the parents and we had a one-to-one discussion. So in here we are using all the 5 elements of the earth: air, water, metal, everything. So this is an electrocautery snare. We go and cut the tumor with the electrocautery snare, and with constant suctioning through the side port, we are able to take the tumor out, and more importantly, give a free margin for this child. And in between, we start using cryo and a lot of other modalities. So where tumor was completely occluding, I am able to see left upper lobe, left lower lobe with the chart tumor side. So we follow them up every 6 months to a year with CT scan as well as a bronchoscopy, and we also take biopsy from endobronchial lesions. So this was the child after 2 years. So absolutely normal. Tumor which was occluding completely is completely healed. There is nothing. So this child was deemed cured. So endobronchial carcinoma tumor, which would have gone to pneumonectomy, was taken care of just by doing a endobronchial resection. So this was another child who had presented with right upper lobe persistent collapse, referred by a pediatrician to us, had bronchial cutoff sign on the right upper lobe. So you can track the airways going nicely. Right upper lobe is completely collapsed, and there is no right upper lobe. So right upper lobe collapse sign or so this was the tumorous lesion on the right upper lobe. This is just in 2 year, 4 month old. And after clearing, this was the airway patency. So this turned out to be inflammatory pseudotumor. So rather than a tumor being there, it was an inflammatory pseudotumor. And probably if you have heard a name called as Anita Borges from Hinduja Hospital, as well as, so she's an eminent pathologist who gives excellent reports on Hodgkin's lymphoma. So I was very categorical, no, this can be not an inflammatory pseudotumor, it can be something that is just sitting there. How can an inflammatory pseudotumor happen in 2 year, 4 month old? She was so categorical in stating that, no, this is an inflammatory pseudotumor. You please go back and recheck the images after say 2 to 4 weeks. You will find that there is no tumor there. And I went back, I saw this. So pathologists are as important as what we do, and unless they don't give us a good report, we are as mediocre as anybody else's. And this was a chest X-ray after therapy. So we can get anything and everything in the airways, and this is something that we are very proud of in our center. So endoscopic closures of tracheoesophageal fistulas, you will have probably seen a tracheoesophageal fistula in your lifetimes, intubated them, ventilated them, got them operated. In a fraction of them, they come back with recurrence. They can come back with recurrence during the same hospital visit. They can come back with a recurrence after 4 years, 6 years, 10 years, 12 years, whatever age it is. So this was a child who had tracheoesophageal fistula. So you can see, sorry, the images have. Sorry, the images have. So this is the slide. So this is the trachea, this is the esophagus, and there is this fistulous tract. So this is a child who was 8-year-old, had already developed bronchiectasis because of not understanding that refistula can happen in children, and child went on having significant wet cough. A child comes to you with recurrent wet cough, it is always a etiology that you should always consider as a problem. So this child had esophageal tracheoesophageal fistula, and this was a fistulous tract from the esophageal side. So what we do is we do both tracheal and esophageal closure. So esophagally, this is the esophageal tract here. So what we do is we go in and we put in something called as OTSC clip from the esophageal side. So this is the fistulous tract from there. So after we put a OTSC clip, so this is the OTSC clip that we put. I'm not going to show you the whole thing, but I'm just going to tell you. So this is how we deploy OTSC clip onto the lesion, and once we deploy the OTSC clip, you can see there is so much of purplish engorgement of the vessels. So this takes care of esophageal side, and once we have taken care of the esophageal side, we also put a cyanoacrylate glue from the tracheal side, that is to close from the tracheal side, and after we insert the cyanoacrylate glue, we put in a stent. So we put in a stent. You can see the stent nicely sitting here. These are beads of the stent, and this is the stent here. This is the Ovesco clip with stenting. So by doing this, we were able to close both esophageal side and tracheal side. This can be done as small as the child that can be presented to us, and more importantly, by doing this, you are preventing a recurrent surgery. So you give this child to a pediatric surgeon, they will tell you, sir, if you are able to close it through endoscopically, please close it. Otherwise, there is a muck inside. There will be so much of adhesions that we will require child to be on cardiopulmonary bypass, and there is so much of morbidity with this that child will have to be at least admitted for at least 14 days, and recurrence rate with the surgical closure again is as high as 30%. Recurrence rate with this closure is only 10%. So 90% successful rate, and after this, child has not come back to us with any recurrence at all. And there is reversal of bronchiectasis, and child is doing very well. So among all the esteemed pediatricians, how many have you treated endobronchial or mediastinal lymphadenopathy as tuberculosis just looking at CT thoraxis or just chest x-rays? So you will see that nice lump on the right hilar region or right paratracheal region. So this was one of that particular child. Endobronchial ultrasound, transbronchial needle aspiration. 7-year-old school-going child presented with fever for 2 months, treated with broad-spectrum antibiotic initially for 3 weeks, changed to attitude due to its persistence. This is what usually happens, isn't it? We treat antibiotics and then we change it over to AKT. Despite 28 days of AKT, child continued to have persistent fever spikes. So this child was referred to us by eminent pediatrician of Bangalore, and you can see there is significant amount of lymph node with so much of pus inside. With this amount of pus, child is not going to get better, and more importantly, we did not have a diagnosis. So what we do is we go inside. This is the pus pointing here. We go map the lymph node from inside. So this is called as endobronchial ultrasound, transbronchial needle aspiration. It is the same bronchoscope but an ultrasound probe in front. So by this, it gives us eyes and tools inside so that we can biopsy the lymph node from inside. So this is biopsying the lymph node from inside. This is like you doing an FNAC of the lymph nodes of the cervical region. I'm doing an FNAC from the inside. So I'm able to take FNAC from inside and send it for investigation. And within 6 hours, we had gene expert positive, rifampicin was resistant. And that was the reason why child did not get better. Rifampicin was resistant and child had not one but two drug. So we sent for cultures, isoniazid and rifampicin resistant tuberculosis. And that was a major reason. And once we drained out the pus came out. You can see that pus pouring literally out. We had to drain out almost 150 ml of pus from airways inside. And after we drained out the pus, we were able to do the APC, organ photocoagulation of that particular area and close that area. See, again, what bronchoscopes we are using are high definition bronchoscopes. These are 6.2 millimeter, which magnifies your images to almost 20x. So whatever you see inside is almost literally like huge magnifications. So apart from that, we also do esophageal ultrasound for children less than 6 years. Again, mediastinal lymph node, child having 1 year, 8-month-old with significant mediastinal lymph nodes. So had mediastinal lymph nodes. So we went ahead, we did a esophageal ultrasound, and rather than putting it through trachea and the bronchus, we put it through esophagus. So it is like you doing an endoscopy. And once we do an endoscopy, you go take lesions from, and that's the heart just below my needle. So it's almost 2 to 3 millimeters just from the left heart. So by doing this, we were able to prove that this was diffuse large B cell lymphoma. So usually the presentation of DLBCL is by superior vena cava syndromes. But in this child, we were able to catch the diagnosis early and start the treatment early. So because of that, child was deemed cured only after 5 cycles of chemotherapy. So we do a lot of EBUS and esophageal ultrasounds in our centers. So where do we usually require it? That would be the major question that pediatricians would want to know. So the most commonest is tuberculosis, drug-resistant tuberculosis, non-tubercular mycobacterium. It is not as uncommon as we think. Non-tubercular mycobacterium is as common as it is. Pyogenic, even in most of the coccidomycosis, all those things we can get pyogenic significant mediastinal lymph nodes. Lymphomas. So we have had a sensitivity and specificity of almost 92% with lymphomas, and thymomas and metastatic neuroblastomas. And ours is the only center which has the largest paper on sarcoidosis, and we had won a prestigious International Congress of Pediatric Pulmonology on a paper on sarcoidosis, 40 cases on sarcoidosis. So we have looked at airways, we are looking at pleura now. We also do a lot of pleural work. 14-year-old adolescent presented with persistent pleural effusion. First presentation, thoracocentesis showed effusion. Treated with oral antibiotic, monitored with serial ultrasound for resolution. Second presentation, similar to us, thoracocentesis done, executive with low ADA. See, our usual understanding of tuberculosis has always been paucibacillary disease, and more importantly, tubercular pleural effusions always are inflammatory reactions, which is absolutely wrong, absurd. Once we started looking into things, we started realizing that you are getting more culture positivities and gene expert positivities on pleural samples than anything else. So we go inside, we look at, so this is the CT image with the significant collapse of the lung and significant pleural effusion. So we do medical thoracoscopy, we don't use rigid thoracoscopy, so we put a port. So this is your pleura. So you can see this is your parietal pleura, this is your lung which is completely collapsed. So you see the sago grain appearance. So nice sago grain appearance. This is like some pimples on your airways. You take biopsies from these pimples, you send it for gene expert. I can 100% assure you your gene expert will be positive. We have the largest number of cases where we have done medical thoracoscopies for all adolescents with pleural effusion, and all of them have had gene expert positive. So again, that rebuts your theory and understanding of pleural effusions being inflammatory. It is not inflammatory, it is always infectious. Until unless we don't look into the pleura, we are never going to understand what is happening to the pleura. And this is how the whole diagnosis has changed. And once we know, the reason why I'm stressing on it is because once you know the diagnosis, if a child comes to you with something called as TB iris, pleural effusions are known to have TB iris. Pleural effusions after starting therapies can come back with again a severe effusion, that is TB iris. That can be only diagnosed if you have a concrete evidence of tuberculosis. You don't have concrete evidence of tuberculosis, you'll just keep struggling with what you're dealing and you'll not be able to answer the parents. Apart from that, we do a lot of pleurodesis and pleuroscopy in our children. We have significant number of spontaneous pneumothoraxes, second episode, third episode. We have significant cystic fibrosis. Ours has we have a CF clinic where we have CF patients under us registered who follow up with us every 3 months, around 40 patients. We have a PCD clinic up and going. So this is one such child, not a PCD child or a CF child, but this was a child who presented to us with renal cell carcinoma. So renal cell carcinoma had metastasis. So you can see lot of pleural metastasis. So he was anyways for palliative therapy. So we always, before we palliate and do chemical pleurodesis, we take biopsies from the lesion. And once we've taken the biopsies from the lesion, we do this electrocautery of that particular area so that adhesion becomes a little bit better. And after adhesion becomes, after that we go in and we spray talc. These are called as graded talc, and this is what we do. This is called a snow burst or snow burst appearance on pleuroscopy, and this leads to significant adhesion. So apart from that, so what we have done is airways, pleura. We also do a lot of parenchymal work. So this is something that I'm really proud of because I was the first person to do it in the world. So first one to demonstrate that transbronchial cryolung biopsies can be done in the world in 2015, and only after that a lot of studies have been done, and which I have been a part of. There was a multi-center trial which was done by European Union, which I was part of. We have the largest case series in India and has been published in Lung India. So 10-year-old school-going child, complaints of dry cough, exertional dyspnea, intermittent wheezing episodes since last 4 years. Also has features of failure to thrive. So everything was suggestive of something that was going on inside the lungs, which was parenchymal lung disease. So this was the parenchymal lung disease. So you can see the CT. So you see the CT, there is so much of, if you see the CT, there are so many small moles inside the lung. So first look at it, you can think this is primary Langerhans cell histiocytosis. But we did a lavage, we showed that there is no CD1A positivity. Then we spoke to the parents, we told them VATS, lung biopsy, 3 to 5 days minimum, cost, cryolung biopsy, tomorrow you go home. You'll get a diagnosis which is equivalent to VATS, and more importantly, there's no morbidity and mortality with cryolung biopsy. So we went ahead and we did cryolung biopsy. So it's the same cryoprobe that I use for taking out a foreign body. So this is a Fogarty balloon which is used to control the bleeding if there is any. I pass a cryoprobe here. The cryoprobe grows inside. It goes as deep as possible until I get a resistance. Usually I pull it back by around 2 centimeter from the pleural surface and then take a biopsy. And I repeat this biopsy procedure for at least 2 to 3 times. And at the end you get a nice biopsy sample. So after a biopsy sample, this is the chest X-ray. There's no pneumothorax, there's no bleeding. Child goes back to the ward, no ICU recovery also. Child goes back home next day morning. And pathologists are so happy with cryolung biopsies now. Adults have given up doing VATS for lung biopsies. And pediatrics, at least in our center, we are categorical in doing only cryolung biopsies. So apart from doing it, again, like I reiterating, pathologist is very important. If your pathologist is not good, it is as good as you don't do a biopsy at all. In our center, we have an excellent pathologist, and she also talks to people from most of the Western countries. So this was reported by one of the leading pathologists, Megan Bishop from Cleveland, and we have a MOU with them, and we just wire them $100 and they give us a very excellent report. This child turned out to be a primary Langerhans histiocytosis, and this was published in our center as one of the first in the world, and post that we have done lot many more. So indications that where we do lung biopsies are childhood interstitial lung diseases, we can have ABCA3 mutation, surfactant protein B, C, or other mutations. Parenchymal diseases, primary idiopathic hemocystроsis, we have had plenty of them. Primary alveolar proteinosis, ours is the only center which does double lung ventilation, that is through endotracheal tube, and does whole lung lavages, which I'm going to talk later. Tuberculosis, sarcoidosis, ILD secondary to autoimmune disorders. And again, ours is a center where we have lot of autoimmune diseases as well as immunodeficiencies. If not heard, we have an excellent immunologist from in our center, Sir Dr. Sagar Bhattad. He is an immunologist who takes care of rheumatology as well as immunology. And because he has so many immunological cases and rheumatological cases, we get a lot of reference for secondary ILDs, right? So, and then whole lung lavage. Whole lung lavages are something that we do day in and day out, particularly for primary alveolar proteinosis. That's the only treatment. So we do in a single endotracheal tube, we do double lumen ETTs. So 2 year, 3 month old presented with persistent hypoxemia lung shadows post mineral oil injection 2 months back, treated in hometown with antibiotics and oral steroids for 6 weeks. Examination, mild tachypnea with room air saturation of 88, systemic examination otherwise normal. So this is a post mineral oil injection, treated with oral steroids for 6 weeks, not gotten better. See, the beauty of mineral oil injection is it stays in your lung, it doesn't go anywhere. Your alveolar macrophages tries to digest it, but because the protein or the lipid molecule is so huge, it tries to digest it, but because it is not able to digest, it just spits it out again. When it spits out the lipid, it also spits out a lot of inflammatory secretions, and all the inflammatory secretions just settles in your airways, causing long-term ILDs. So this is your airway, even despite 6 weeks of oral steroids. So what we do is we do single lumen, 2 year 4 months, we can't do a double lumen ETT. So we do a single lumen ETT, and we do segmental bronchoscopic whole lung lavage. So we put almost 3.5 liters on one side, and again 2.5 to 3 liters on the left side, and do it in the same setting, and we are able to get the lung back to normal. So this is just taking us 48 hours of our work, and this was the amount of fluid that we were able to take out from the lungs. So the same thing we do it for alveolar proteinosis. So we have primary and secondary alveolar proteinosis. So congenital, we have primary alveolar proteinosis, we have CSF2 alpha and beta mutations, Mars mutation, LPI mutation. So we have all of them in our centers. Mars mutation, just recently we have published in Indian Journal of Pediatrics. Apart from that, mineral oil injection and secondary to autoimmune disorders, particularly SLE, because of it is autoantibodies can cause anti-GM-CSF antibodies and leads to significant PAPs. There we do whole lung lavages. So in this particular child, we did with a single lumen, but in older children, more than 8 years, we put a double lumen. So we do selective lung ventilation and we do whole lung lavages. And this is something that I'm really proud of. This is something called as perfluorocarbon. I hope neonatologists here, if people have practiced neonatology, in 80s and 90s, there was a very huge thing about liquid ventilation. Has anybody heard about liquid ventilation where they would give perfluorocarbon to ventilate the lungs in severe ARDS? Probably no. So probably only few people from 1980s then. So 8-year-old school-going child with persistent collapse of the left lower lobe for 4 months. So this was evaluated as TB and was planned for AKT. Because of persistence of cough. So which is what we usually see, isn't it? So a child comes to us, doesn't get better, treat antibiotics, 2 course, 3 course, doesn't get better. You have lavage services, you get it done. You don't have lavage services, you go ahead and start AKT and see if things works. So refer to us for confirming that it's that really tuberculosis or starting AKT. On presentation to us, child was actually very cheerful with and very comfortable in room air, no significant history of weight loss, appetite or recurrent persistent fevers, well nourished and significant, but there was significantly reduced air entry in the left lower lobe. This is the first chest X-ray. So usually in these scenarios, what do? We do a lavage. We actually send it to a bronchoscopist to do a lavage, and we did a lavage. After doing lavage, 2 weeks later, we got a chest X-ray, no improvement. We looked into the airways are completely clean, absolutely nothing. We went inside the left lower lobe, absolutely nothing. So there is a word called as plastic bronchitis, where your phlegm gets stuck like a plastic and it comes out like a tree that is taking the shape of the bronchi and bronchioles, and we pull it out till like tree. Nothing of such sort. So again, we told the same thing to the parents. Did a bronchoscopy. This time we waited for 4 weeks with proper chest physiotherapies, 3% hypertonic salines. Still not got better. So parents also started getting a little bit more worried. They started questioning, you've done 2 lavages, we've spent already so much of money, still lung is not opening up. What is your plan? What is your plan? So we told them, see, this doesn't look like normal. We don't know what is the cause. First thing is, we tell them what is the probable reason. We did not know what is the cause. There's no ILD here. There's no diseases which can cause significant airway secretions like PCD or cystic fibrosis. Did not have any signs and symptoms suggestive of one. And more importantly, did not look like any immunodeficiencies. So at least we did a little bit of primary immunological workup and all. And because we have a sweat chloride analyzer, we also went ahead and did a sweat chloride analyzer. Absolutely nothing. So we were left with nothing for this child. So how do we open this up? Should we just leave it alone or should we do something? So we did something called as perfluorocarbon. So this is the perfluorocarbon. So it is a chemical which is was used as liquid ventilation in neonates for ARDS in 1980s and 1990s, where they would flood the lung with PFC. Perfluorocarbon has a lot of viscosity. It is very thick. You take a pen and drop it on PFC, it just floats on it. But it has a very high oxygen carrying capacity. So you drop it into the left lower lung. You see that left lower lung is the whole thing is going into the left lower lung and it is improving. And more importantly, it started improving, and we kept the child intubated, ventilated for next 24 to 48 hours. We did serial x-rays to see how it is improving, and after 7 days of perfluorocarbon, left lower lung opened up. So again, this is the first child to be undergoing perfluorocarbon in India. So from here to here, after doing 2 lavages, almost 6 weeks of hypertonic saline nebulization, N-acetylcysteine, and 2 weeks of DNS. DNS is not cheap. It costs 2,500 rupees per vial. We gave 2 weeks. So parents had exhausted resources. So we told them this is the only possible option. This is called as Liquivent. So it is Liquivent that we use. It is radio opaque, so we are able to see it under fluoroscopy as well as after x-rays, and this was the chest x-ray. So these are the ways that we can change a lot of things, and these are the ways that we can bring about changes in children's life. And like I said, I'm reiterating, we start thinking where others stop thinking. Thank you. So any questions, I'm ready to take. For this child, for the last child, we don't know what the diagnosis was.
It was a constriction over there. For what?
There was nothing, just collapsed.
Just collapses.
Just collapsed. So we did not know what the reason was.
It got opened.
So once we see, at the end of the day, there's only so much we can do to open a collapse. So we can do lavages if there is secretions. We can give them bronchodilator therapy if there is a lot of bronchodilation, bronchorestriction. If there is stenosis, try to open the stenosis. Beyond that, there is nothing else that we can do. But this has given an added advantage to us. By instilling perfluorocarbon, we are able to open it up. Because of the viscosity, see what happens is, what we have learnt is, when we have collapses, there are small micro webs forms inside your airways. So we can't 100% tell you that there are microwebs inside, because there is no way that we can go inside 13th generation, 14th generation airways, but those microwebs will not break. You push saline, it doesn't break. You push something that has a lot of viscosity, which is very heavy, it just rips apart. And that is the reason why probably the lungs have opened up. And those microwebs have to be opened up with a lot of tension. And this causes a lot of tension to your airways.
Second question is about lipoid pneumonia, isn't it? You have shown lung lavage with the 3 to 4 liters of normal saline. So we added 2 cases actually and we lost it. आपल्याकडे खोबरेचं तेल पिऊन येतात ना पेशंट्स, खोबरेचं तेल पिलेलं असतं आणि ते चेस्टमध्ये जाऊन निमोनिया होते तेव्हा काहीच करू शकत नाही आपण. सो दे हॅव डेव्हलप्ड bronchial lavage with a lot of saline. Sir, my question is that when you lavage it, we lavage it 2 ml per kg, max to max 5 ml per kg. So doesn't it take out a surfactant which is important for avoiding preventing the collapse of the alveoli?
Definitely it takes away surfactant.
Sir,
but
are you pushing then again surfactant after that?
no, it doesn't require, because production of surfactant hardly takes 4 to 6 hours.
Oh, okay.
And until unless you don't take off the excess protein,
Uh-huh.
excess lipid from your airways, you will not be able to produce your normal surfactant at all.
Yeah, that's true.
So that is the reason why once you take out the surfactant, because your alveolar type 2 cells are still intact, they will anyways produce surfactant.
So how many days? Because we tried it after a few days, 8 to 10 days. But how many days? Then we could not survive that baby. So how many days? When the duration have you calculated in your so many cases? After lipodemia, how many days? Within how many days we have to do the lavage
See,
with so much of a saline?
See, normally we start with oral steroids or IV steroids, whatever your, depending on the clinical condition of the child. If child is improving, because you just have to prevent the inflammation part of it, and most of it is taken care by your alveolar macrophages. And again, it depends on the quantity.
How much it
So
is?
how much has the child actually aspirated? Very small quantities and all. A lot of children come with a lot of kerosene oil injection. A lot of children will come with that mineral oil injection, which is kept on sewing machine. So small quantity doesn't cause any problem. If it is a large quantity, you have trialed 4 to 6 weeks of steroids, still continues to have persistent problems, then only we go ahead with whole lung lavages. But again, if child is not at all stable, then also we go ahead with whole lung lavages. But in those scenarios, we put them on cardiopulmonary bypass, then do whole lung lavages, because we don't want any untoward side effects on the same day.
Yes, thank you very much.
I think everyone needs tea break now. We'll just go for tea break. Yes, one question is there.
Is there any role of virtual bronchoscopy?
So virtual bronchoscopy,
They are not able to say whether there is a foreign body or not. We suspect foreign body. Then to do the bronchoscopy in such a child, it requires a lot of money and time. So what is the role of virtual bronchoscopy in this?
so virtual bronchoscopy has very low sensitivity and very low specificity. So that's a very, very important thing, that when you have such low sensitivity and specificity, so studies have looked at chest X-ray versus normal CT versus virtual bronchoscopy on CT to diagnose a foreign body. Chest X-ray is able to diagnose only in 50% of children. That too, if it has classical hyperinflation or collapse of that particular part, then only you'll be able to. So 2 cases that I presented did not have any signs at all. And CT thorax has sensitivity and specificity of only 70%. And virtual bronchoscopy also has the similar. So it can mix 30% of cases in foreign bodies particularly. And virtual bronchoscopies can only look until up to right bronchus intermedius, never beyond right bronchus intermedius. And our foreign bodies are usually lodged in the right lower lobe bronchus or a little deeper inside. That is where virtual bronchoscopy has absolutely no role, and it is more radiation compared to a normal CT. So we usually discourage not doing any. And more importantly, sensitivity and specificity of a bronchoscopy in foreign body diagnosis is 100%.
Achha, one more thing. Now you said that it is difficult to remove the foreign body with a flexible bronchoscope. Now your rigid bronchoscope, has it got a airway, this thing, oxygen administration along with the bronchoscope?
All rigid bronchoscopes have ventilating ports, sir. So not that I'm saying 90% of the children we use only flexible only. Only in 10% of the children where subglottis is pretty small and we are not able to take the foreign body out, in those children we put a rigid bronchoscope. And putting a rigid bronchoscope is that much more easier. It is like literally the easiest thing that you can ever do. And ventilating through rigid bronchoscope gives us that peace of mind of operating and doing things. And whatever procedures I've showed you, all are under rigid bronchoscopes only. Because they require a lot of manipulation, they require us to pass a lot of equipments inside, and we want an anesthetist who is ventilating side by side. Only when we ask them not to ventilate, particularly when we are using hot instruments, that is APC, electrocautery, we ask them to come down to 21%.
Now you have shown some cases of congenital laryngeal stridor where you have put on the rings around. How frequently you have to use this absorbable rings around?
Which one, sir? Absorbable stents.
Strain.
Sir, absorbable stents, we put it only to tide over a crisis. So just recently we had a child referred to us from Jipmer Pondicherry. So child had only one lung, left lung, and that was also very severely malasic. So child was not at all extubatable and was having lot of difficulties, never could not extubate at all. So they came to our center, we just put a bioabsorbable, biodegradable stent. We extubated the child. Within 6 to 8 weeks, the stents gets reabsorbed. And because child was thriving well before that, so we did not have to do too many things also.
First of all, heartiest congratulations. You are doing extraordinary work, which is wonderful. I think he needs a big round of applause.
Thank you.
And as you said, you start thinking where our thinking stops. I have two questions. One is sometimes we stuck up with the big bronchopleural fistula. Air is going, child is on ventilator, we cannot extubate also. So can this, you can plug at that or can you do for this bronchopleural fistula?
Definitely, sir. So we do something called as endoscopic glue insertion, and we have something called as spigots. So we first see what or which bronchi or bronchus or bronchioles are causing bronchopleural fistula and causing air leak. We dilate the balloon, that is Fogarty balloon that I showed. We see which one is actually leaking, and we also do the other subsegments, but we go and segregate which is leaking. Then we put a Wantanabes spigot, or we also customize spigots in our center. Push that spigot, put glue on it, give at least 4 to 6 weeks time for the fistula to heal, and after that we take the spigot out.
Because that is otherwise we have to go for the surgery, and that is removal of lungs. That is a big surgery for the child. Another thing, the TO fistula operated babies, after 6 months they come with 6 months or 1 year come with the tracheal stenosis. So what you do for this babies?
So for tracheal stenosis, we do balloon dilatation first, balloon tracheoplasty. If balloon tracheoplasty, when doing only, we analyze, is it a complex or is it simple? Simple usually get better without doing too many things. But complex, we go ahead with stents, sir.
That will be permanent because child is growing.
6 months, sir.
6 months.
Only for 6 months. You just help the airways to become normal, the fibrous tissue to form around the stent, and then you take it out. Usually around by 6 months, we take the stent out.
Last week I had a severe laryngomalacia. It was not maintaining the, after extubation again we have to reintubate. So we referred to Pune, they did some laser surgery, but that also failed. And they end up with the tracheostomy. So can we avoid the tracheostomy in this, because I had 2-3 cases of severe laryngomalacia requiring tracheostomy in neonatal period.
So laryngomalicias, if they are going on to tracheostomies, it's frowned upon now. So surgeries are being done with utmost care. See, again, aim is not to reduce stridor. Aim is to reduce breathlessness. Aim is to allow child to grow well. For that, you don't overdo surgery. If you overdo surgery, you'll end up in problems. So do as much as required. And more importantly, if they are floppers, you just touch with electrocautery. If they are curlers, you just release a little tighter portion so that it becomes slightly loose and child is able to breathe comfortably. So again, doing laryngeal surgeries, if a person knows what he is doing, it's easier. Everybody starts doing it, it becomes a difficult job.
Okay. Thank you. Thank you.
केले ते रिजिड ब्रॉन्कोस्कोपी नव्हते, सगळे दाखवले ते फायबर ऑप्टिकवरच दाखवलेले ते खूप कमी रिजिड. वी डोंट डू ॲक्च्युअली रिजिड नो ॲक्च्युअली. सो दीज आर ऑल थ्रू यू आर डुईंग इट फ्लेक्झिबलमधूनच केलेले आहेत ते ॲक्च्युअली.
Now the rigid bronchoscope has a ventilating port.
But in fiber optic there is no ventilating port.
So fiber optic we don't have.
We
We
don't have.
oxygenate the child and simultaneously we do.
फास्टर जाऊन फास्टर द्यावं लागतं त्याच्यामध्ये.
Thank you.
थँक्यू डॉक्टर श्रीकांता. काही शब्द येत नाही, OMG फक्त. जस्ट ओ माय गॉड, इज सो नाइस, सो स्पीचलेस. कुछ भी थैंक यू भी नहीं निकल रहा है. इतना अच्छा मेस्मराइजिंग टॉक, इजंट इट? यस और नो? यस. सो बहुत ज़ोर से ताली हो जाए और टी ब्रेक के लिए हम लोग ब्रेक करेंगे फिर. बट आफ्टर टी ब्रेक ऑल्सो वी हॅव 3 ब्युटिफुल लेक्चर्स. सो सगळ्यांनी जमा राहायचं आहे, जायचं नाही आहे. I welcome you all for the second session. I welcome Dr. Sandeep Kulkarni, who everybody knows him. He is a very eminent pediatrician of Solapur. He is a director of Span Critical Care Center. I welcome him.
Good afternoon, everybody. First of all, I thank Solapur Academy of Pediatrics, Dr. Kundan, Dr. Pratibha, inviting me to give this very small sort of speech. Maybe it is important, maybe in future it will be a very big thing. Let's see. But definitely after such a nice lecture and such a nice presentation by our eminent speaker, Dr. Srikanta, I am just going to have a small talk on this. Multiplex biofire, usefulness in respiratory conditions. So, what is this biofire panel in pediatric respiratory diseases? We'll just go through it. It is called a syndromic approach when there are symptoms, symptom-driven broad grouping of probable pathogens into one rapid test that maximizes the chances of getting the right answer in a clinically relevant time frame. So many times when we see patients in front of us, the child is in obvious some distress, respiratory distress, having high grade fever. Maybe the patient has already traveled from some patients, some doctors, and he has come to us. And by now, the patient relatives, specifically Google parents, they are very much anxious about what is going through my child is going through, and how fast he will recover and everything. So all these answers maybe in one short visit we will not be able to give. But many times we have to struggle a lot to find out what actually the child is going through, and we have to give them answers. Not only that, we have to treat the child, and we should see that the child should come out of this condition as early as possible. So lot of diagnostic tools are available for diagnosing, finding out what is wrong is going on in this child, like imaging, cultures, antigen detection or antibody detection. Few are very not precise, but few are also time consuming. So we can't say that we'll be sending a culture and we'll wait for 3 days, and after 3 days when we'll find the microorganism, then we'll start an antibiotic. So we can't do. And then what we end up is we are giving a broad spectrum antibiotic. We are giving multiple antimicrobials. Maybe we also tend to start some antiviral, and we give an umbrella like treatment for this child and hope something will be hitting the thing. Now nucleic acid amplification, that is NAT test, are gold standard test, and biofilm array is one of the answer for this. Now this is the differential diagnosis can be difficult in such cases. Now you can see the X-ray images. This is a 1-year-old where alveolar infiltrates are there. Then this is a 7-year-old. He is also having alveolar infiltrates. Here also here are interstitial infiltrates. But these X-rays will become very confusing. Now this is because of human retrovirus, this is because of human metapneumovirus, this is because of adenovirus, this is because of enterovirus. So but how can we come to know what pathogen, what microorganism is going inside, and all the X-rays look similar? So for that we go through this long list of diagnostic tools. Some are time consuming, some are labor intensive, some are technically very complex, some have very low yield. Many times we get culture sterile, even if we see that the child is having such a big pneumonia. Even pleural effusions also, as sir said that he is picking up so many cases, but many a times pleural effusion also they come to us as a sterile. Then lack of sensitivity and specificity, or they are cost overreads, or there are some limited coverages, and all these things overlapping symptomatology, need to order multiple tests, and unavailability of the test for many organisms. So all these things put together, we come across what have to be done for this kind of cases. Now, what a clinician needs is antimicrobial stewardship. So it should be a backbone of our therapy, that we should hit the organism with particular antimicrobial that is very effective. So we should be coming out to a narrow spectrum to one or two antimicrobials to hit the organisms. Second thing is diagnostic stewardship. We should be precise in our diagnosis, not only saying it's a pneumonia, but we have to become whether it is a viral, whether it is a bacterial, which bacteria is causing this, which virus is causing this. We should come to that end. Second thing is we have to adhere to hospital antibiotic policy. It is very must. Then judiciously we should escalate or de-escalate in some patients. Sometimes we know that this is a viral. We may de-escalate some antibiotics in these cases. Judicious antibiotic use, which has to be rational. Second is control of antimicrobial resistance, which is really must today. Periodic clinical audits in the hospital itself. How many cases we are presenting with a particular type of organism in this hospital, and infection control and positive outcome, that is a key of treating the child. So what is traditional versus syndromic testing? In traditional testing, we see one sample, multiple tests are ordered, then results take hours or days. Individual test results are separate reports. So we'll get one report of culture in different way, and we get X-rays in different, CT scan shows something different. So it can confuse again. And of course, the longer patient stay, the hospital cost is also increased, and the patient have very difficult days to stay at length in the hospital. But in syndromic, one sample, we can go for comprehensive testing, which takes literally few hours for the results, multiple results in one report, and definitely it will reduce the hospital stay and improve the hospital management. So what is it? BioFire. We have to just go through this, we have to load the sample. I am just going through this technical things, but how easy it is. We have to just load the sample, and it is just taking 65 minutes for the run time. As it sees, sample moves into the lysis chamber, cells and pathogens are lysed by beating and releasing nucleic acids. Nucleic acids bound by magnetic beads move from the lysis chamber to the purification chamber. A wash buffer removes cellular and pathogen debris. An elution buffer removes purified nucleic acids from the magnetic beads. Later, nucleic acid moves to the first stage PCR chamber. Reverse transcriptase converts the target RNA to DNA, followed by a high order multiplex PCR. Products from the first stage PCR are diluted to remove any remaining PCR primers. Later on, first stage PCR products are added to fresh buster mix and are allocated into each well of the array. Each well is then pre-spotted with single pair of second stage PCR primers, resulting into specific amplification of the target DNA only, and a fluorescent double-stranded DNA binding dye monitors each reaction. Hence, we can precisely find what organism is going on inside the patient's body. The film array performs a melt to confirm the presence of or absence of assay-specific temperature signatures of the second stage PCR product for each well in the array. So, as we see, now we are only focusing on respiratory infections in children. In respiratory panels, we can see all these viruses can be detected by bioarray in just 1 hour or maybe few hours. And all these atypical bacteria also, and some even fungi. So all these things in one set, one diagnosis or one report, we can find out all these things. So sample can be nasopharyngeal swab, it can be transport in the transport media, and sample as less as 300 microliters is needed, and performance is 97% sensitivity and almost 100% specificity. So we can definitely rely on these reports as it comes very early, and we can start the treatment as early as possible. Now, what are the applications of syndromic approach? One is to detect relevant pathogen involved in the disease, to detect unsuspected pathogens, to detect additional underdiagnosed pathogens, to detect any co-infections in the child, to help the clinicians in decision making in patient management, to escalate or de-escalate antimicrobials, to generate savings at the hospital level, definitely, because the hospital stay of the baby is going to be less, and negative results is also important as a positive result. So many times we may get a biofire negative. So definitely we are going to rule out as many organisms which are not there in this child. Methodics is very simple: collection of sample like nasal or pharyngeal swabs or BAL or modified BAL techniques or tracheal secretions, which can be collected by trained staff or even laboratory technicians, and loading sample in the machine, it takes hardly 2 minutes, and around 1 hour to 2 hours the run time, and the results are available. What are the disadvantages? One is definitely cost, because it may be costing in some centers maybe around 15 to 16,000 to maybe around 20 to 25,000. It depends upon the center, but still we can ask, because many times it is available in Ashwini, and we call our microbiologist and ask her to reduce the price because the patient is not affording and all those things, and then they reduce a bit of price, but definitely it is a costly affair. So, but early detection of microorganism, timely use of right antimicrobials, early recovery and reduce hospital stay, definitely they are important. So cost may not be that important. Second thing is anxiety regarding detection of other co-infections. So especially in past days, coronavirus used to come in that bioarray, and everyone used to get stunned whether this is no, but we discussed at length with microbiologist, and then she used to tell us, Nini, this is not that coronavirus we have to be worried about, so we can continue the treatment in the same setup. Could be dealt by clinicians and on the clinical grounds. And availability, maybe it is not available in every city or every juncture, but even if it is available in nearby cities, the results are available early, so we can take that chance of sending the patients to the nearby cities. To summarize, syndromic testing is the need of hour. It is fast, easy and comprehensive. It's fast, rapid sample to answer, turnaround facilities, timely targeted therapy. It is easy, it is automated, user-friendly platform, requires just 2 minutes of hands-on time. It is comprehensive. With over 100 targets, we provide the largest infection disease pathogens menus on the market. The biofire system positively impacts patients, physicians and everyone in between. Each syndromic testing panel offers several proven benefits and empowers healthcare providers to choose the right test the first time. Thank you. Thank you very much. Right. It can definitely give, but what they used to, the answer given by microbiologists is, they only screen those viruses which are important because they may produce other organisms also, but they will just do the PCR, what to say, detection of those viruses which are clinically important. Sir, can you?
Because it is a syndromic, like you said, sir, there are very high false positives. So if you are suspecting adenovirus, you are sending for adenovirus and you get adenovirus, then it is clinically relevant. But during the same sample you get mycoplasma also, Can mycoplasma be just a false positive? Yes, it can be. Because your adenovirus has typical pharyngoconjunctival fever. It also has a significant amount of breathlessness. So you are thinking adenovirus, but at the same time, you will not do what you are not supposed to do. That is, give meropenem, give piperacillin tazobactam. That is the whole point of biofire. It has, you can get acinetobacter also, you can get other organisms also. It is just a way to tell, until unless there are specific viruses that are checked in your center. So in Bangalore, what we are doing is, we have kind of streamlined a process wherein we send only those viruses. We don't have an array of viruses. So we only have 8 viruses or 10 viruses which are common. So that helps in reducing the cost. So 20,000, 18,000 has come down to only 6,000 rupees. And because we are doing at 6,000 cost, we are able to do it in every IP patient. No PICU patient, every IP patient. And parent is happy that you are getting a diagnosis. So we had a pandemic only of adenovirus from August to almost March. Every sample we would send was adenovirus, and we were able to tell parents this is going to last for so many days. We are going to de-escalate antibiotics, and more importantly, we were able to tell them when the child went into post-infectious bronchiolitis obliterans or adenovirus induced HLH. That this is because of this only, and we have to be a little careful, and if the child is not responding, we might have to start using your immunoglobulins and other things.
Are you using in the OPD setup also? Means
6,000 rupees in OPD setup is too expensive.
Yeah. But in all IP patients?
But all IP patients, as soon as they come in, we suspect a viral infection, we do biofire, but it is tailor-made to our center, sir.
Okay.
So whatever viruses we are commonly seeing in Bangalore, only those we are sending. And more importantly, you can talk to the company and tell them that these are the viruses that we want. So they will cut down the cost and give you a little bit more comprehensive evaluation of things at a cheaper cost.
Thank you.
Thank you, Sandeep. Even though we are doing it, we could know what is the exact procedure and all. का हे बायोफायर का इम्पॉर्टंट आहे, इतकं कॉस्टली करायचं का, हा प्रश्नाचं महत्त्वाचं उत्तरासाठी मी संदीपला दिलेलं आहे की ह्याचा आन्सर वी गेट इट. बेबी सिरियस व्हायला की वी शिफ्ट टू दी मेरोपेनम एंड कोलेस्ट्रीन. दॅट इज वॉट वी आर अब्युजिंग इट. इफ इट इज सर ॲज टेलिंग इट इज ॲडेनोव्हायरल, वी कॅन कट डाऊन द कॉस्ट ना, अँड ऑल्सो रेजिस्टन्स. सो वी आर गेटिंग सो मच ऑफ अ रेजिस्टंट बॅक्टेरियाज इन अवर ICUs because we are abusing them. Adenovirus is going to remain for 15 days, 20 days. है ना. So still we are using 2 दिवसात 3 दिवसात बरं झालं नाही तर we are shifting to the higher antibiotics. That we can cut down. That is very very important. When specifically they ask it का बरं होत नाही, त्याचं उत्तर आपण देऊ शकतो. When we ventilate the patient, that time it's very easy to do BAL. From that BAL it is false positive is very less. ब्रॉन्क्युलर लवाजमध्ये जे असेल ते फ्लुइड इज व्हेरी स्पेसिफिक रादर दॅन नेझोफेरेंजियल. नॉर्मल कमेन्सेस काढून टाकलं तर सगळं येऊन जातं. बाल इज व्हेरी स्पेसिफिक. वी गेट अ स्पेसिफिक ऑर्गॅनिझम दॅट टाईम, राईट. येस. नाव आय अगेन इन्व्हाइट डॉक्टर श्रीकांता फॉर गिविंग वन मोर नाईस लेक्चर. वी आर ईगर टू हिअर यू, सर.
So this is more or less one-on-one interaction, nothing else. So this is going to be more of interaction than anything else. So before I go to myths and facts from patient's perspective, from other perspectives, I wanted to know what are doctors' perspectives regarding asthma. What do you commonly come across? What do you commonly do, or what you commonly do not do? And more importantly, how do you take it forward in terms of counseling parents? Because that is what is the crux of the whole presentation. Because I'm going to talk about what parents think. I'm going to talk about what the parents as well as their relatives will think about asthma. But the doctor's perspective is doctor's perspective. So the doctor's perspective comes from the clinicians who are sitting in the audience. So I would want to ask everyone here who has been practicing asthma or handling these children, what do you guys come across you consider as a myth or a fact, or how do you convince them that this is a myth and this is a fact? Anybody? There's no right or wrong.
So I actually trained my assistant. So she trains everything. So it cut my time actually. I give only 5 minutes for the patient and tell them this is under 5 years. I trained her, पूरा nebulizer वगैरह everything, huff kit, everything. She trains and again sees ki whether she does correct. This cuts on my time.
So that is about training, but doctor's perspective about asthma.
Our perspective is the scientific perspective, what Gina says.
Right. So again, there I would come. So Gina, we have to take it with a pinch of salt. So a lot of Canadian society, American societies, as well as when we had this asthma training module just recently, we also were kind of because we cannot take everything what Gina says. It has to be tailor made to our practice, and more importantly, we have to make sure that whatever criteria, even though Gina is taking all the 76 countries, all the countries included, it is trying to give a guideline, but that guideline might not be straightforward applicable to you. So if you start telling take MAT therapy in small centers, people will only use MAT therapy. They will never go to any other thing. So all those things have to be taken in a little bit of perspective, and more importantly, Gina says for under 5, never use LABA. But you cannot do that. If a child is coming to you so many times and unless you do not know. So thus recently we had so many difficult to treat asthmas. We started on ICS, not got better. Started on LABA, not got better. Started on Montelukast, not got better. And then we started them on azithromycin. So 4 medications to get them better. But there are other groups of children where there are only neutrophilic. So Gina says only at 5th stage or 5th level you do phenotyping. But unless you do not do phenotyping, you cannot go back and say that this is a neutrophilic variant where I will use only azithromycin. So we have had success with only azithromycin in children with wheezing because they have neutrophilic. You pump in as much as steroids you want, you pump in as much as Montelukast you want, child is not going to get better. And parents have come back and told, just 3-4 doses of azithromycin gets my child better, whereas months of inhaled corticosteroid does nothing. So again, GINA guidelines have to be taken with a pinch of salt. GINA guideline is not like our birth GT which cannot be changed. It has to be taken with a pinch of salt, and it has to be tailor-made to your practice. Your child comes to your clinic, you have to make sure that you follow what is followed all over, but at the same time, child gets better. Yes, madam.
So if adding azithromycin is not nonsense for me in pediatric asthma, if clinically the child is, I cannot judge clinically that it is neutrophilic or eosinophilic. So I have to follow the GINA guidelines also.
No, it's not that expensive, madam. It's just CBC and serum IgE. That's it.
Okay.
With that, you are able to tell you it is eosinophilic or neutrophilic or IgE based. If IgEs are normal, eosinophils are normal, and child is still coughing and wheezing, you can still go ahead with ICS plus azithromycin rather than doing ICS LABA or ICS Montelukast. And azithromycin reduces the steroid toxicity, and azithromycin also makes sure that it does what it is supposed to do, and studies have proven 3 to 6 months of azithromycin has much more beneficial effect than you giving only ICS. So, see, that's what I'm saying. You don't practice GINA guidelines blindly. You do it according to your center and what you are comfortable with, and more importantly, in your center, what is available. See, not all centers will have lung function test. So you cannot do a lung function test. In that you told the PEFRs can be done. Again, PEFR, for every child to do, you need to attach a mouthpiece. That will cost another 150 rupees. So even though cost price for you will be lesser, but still 150 rupees. So on 115 rupee on top of doing those things will be a little bit of challenge. Anything else that doctors feel is difficult, or doctors feel that asthma, because I'm not going to cover doctor's perspective. It's going to be more of patient's perspective.
Regarding counseling, we face problem. When we label the child asthma, they don't accept it. Then we have to do a lot of counseling for them.
That's absolutely true. So asthma is a diagnosis of counseling.
Even after counseling, they will not accept it.
They'll change the doctor, sir. They'll change the doctor.
They will not change the diagnosis, they will change the doctor.
They change the doctor. The only thing is that the other doctor should tell this is asthma. If the other doctor says,
That's
no,
why
this
more
is not
of
asthma,
this
don't worry.
symposium are required.
May not tell that it is asthma, but continue with the
Exactly.
That's why more respiratory symposium are required.
Anything else that doctors feel, because that is something that we don't address. What's doctor's perspective? We always talk about patient's perspective, patient's perspective, patient's perspective. Any other thing that doctors think? So basically, like sir said, telling the diagnosis. See, if a child comes to you with atopic dermatitis, child also has allergic rhinitis at 2 years, 3 years, and also has recurrent episodes of wheezes, there is nothing wrong in calling it as asthma. The faster we say, the faster they understand that there is a problem and they will accept the diagnosis. See, we don't give the due credit to the parents. Initially, there will be resistance. See, if somebody tells me you have a disease, obviously I'll be in a shock. But only after a certain time or a certain period of after medication that I'll get into sync. So once you tell them that yes, your child has asthma, they will understand. You don't tell them that child has asthma, they are never going to understand. That's number one. That's with diagnosis. Diagnosis from doctor's perspective, until unless I am not comfortable telling asthma, then it is going to be extremely difficult to convince everybody that you have asthma. So that's number one. Second, most importantly, what I have come across from doctor's perspective is starting inhalers.
Yeah, it's very difficult.
So doctors themselves are not, because I have had patients coming and telling me that the doctors have told that don't start steroids because it has side effects. That is something that I come across each and every day, because for me bread and butter is, I don't do general pediatrics, so for my bread and butter is asthma only. So when I come across something like that, it adds another 20 minutes for me to counsel. Say, I don't see 100 patients. I have to be very frank with you. I see only 20 patients a day, not more than that. But the 20 patients also, if you don't give the 20 minutes or 25 minutes to them, they are never going to come back to me. So the scare or the understanding of steroids is not there among our pediatricians also. So either somehow, that is what we were discussing in the ATM, somehow we have failed in putting it across to all the pediatricians, particularly the budding ones, particularly the postgraduates, that steroids are the standard therapy. That is the reason why Gina has taken out controller or reliever therapy and they're just stating it as anti-inflammatory therapy now. Not the MART therapy, but anti-inflammatory therapy even for budesonide. So we ourselves not understanding how steroid works. And there is no better medication than inhaled corticosteroids, at least for now, until we get genotyping where we can start doing targeted therapies. Right? Other than that, the other common things that we usually get is from the doctors. Even though they know this is asthma, they always try to convince the parent that child will outgrow by 6 years. It doesn't happen. Isn't it? It doesn't happen. See, COVID 2 years, no child went to school, no infections. Everybody thought asthma went away. Asthma was completely gone. Come next school season, everybody landed up with very bad wheezing. So we did not have, because it was parents' perspective, as well as because doctors had told by 6 years asthma is going to vanish, and some doctors will say 12 years, some will say 15 years. But when they come back with very severe episodes, it takes another extra 10 minutes for us to counsel that asthma never goes away. Asthma will still persist. It's just that because the number of viral infections have come down, the severity comes down, and more importantly, the frequency of falling ill comes down. So 6 years to a certain extent reduces the severity and reduces the exacerbations, and more importantly, coming frequently to you comes down. But other than that, asthma never comes down. So these are the most commonest doctor's perspective that I have personally faced in my clinical practice. So steroid phobia is the number one. So unless we put it across to everybody in the audience that steroids are safe, steroids not only for 1 year, say my father has taken it for last 50 years. He has zero side effects. He still continues to take inhalers. He's not had even single exacerbation. In Bangalore, if somebody has visited Bangalore, we had only one government hospital in Bangalore at that time. It was Vani Vilas, 1950. And they would only give hydrocortisone and injection adrenaline for anybody who come with severe exacerbations. Nothing else. Because of which he developed early onset diabetes, early onset hypertension. At 30s he developed, because he has received so much of adrenaline and hydrocortisone that eventually he had to develop one. That is not happening with inhaled corticosteroids. And last but not the least, please do not use levosalbutamol syrups in your clinical practice. Levosalbutamol syrups has not only shown to increase severity, it is also causing significant amount of exacerbations. We've had children coming to us with 2 months, 3 months of recurrent episodes of wheeze. So you give them once is enough. Parents will start thinking that this is the syrup that we have to use multiple times. See, for them, giving doctor's fees is the biggest burden in life. They can go to a mall, spend 500 rupees, 1000 rupees for just buying a piece of ice cream, but 500 rupees for a doctor is the biggest burden anybody has in our community. So, please refrain from giving levosalbutamol alone. You want to give, please give budesonide or anything that you prefer as inhalational therapy. You prefer. I am not saying this is right, that is wrong, which you already know what is right, what is wrong. But please use inhalational therapy. Intermittent therapy is also valid therapy now. Please kindly use it, because unless we don't do it from our side, parents are going to misuse our trust and misuse the medication that we give. So with this, I'm just going to, from patient's perspective, myths that we usually get from patients is disease, disbelief in the diagnosis, and that leads to doctor shopping. So like Sir said, once you say that this is asthma, first thing is they will sit with you, they will ask you questions, they'll ask you all unwanted questions and wanted questions, and next thing they do is they go to the next pediatrician and ask them, the other doctor said this is asthma, what do you say? If the other doctor says no, this is not asthma, this is allergic cough, they just get stuck with that allergic cough and continue with that allergic cough. So when they come to me, I always tell them, allergic cough, allergic wheeze, allergy, anything is nothing but asthma. You eat like this or you eat like this, you are going to eat only. You want to take the long route, you want to take the short route, please take that route, but you will end up having asthma only. So you are confident in your diagnosis, nobody else can do anything about it, and they will understand. And once you tell them that this is asthma only, reasons to define why it is asthma, they will understand that. And like Madam said, 4 weeks of inhaled corticosteroid therapy, ask them to review, they will understand. Just by giving 1 puff in the morning, 1 puff in the night time, my child is absolutely fine. No nighttime cough, no daytime cough, no exercise-induced coughs. The parents will be much more comfortable. Cough has to be really bad or child has to be breathless to be called wheeze or asthma. So I think all of us here agree that this is not true, isn't it? So asthma can produce in multiple ways. So we've had children coming to us with only deep sighing breathing, nothing else. Child is doing this multiple times. The parents also first initially think this is nothing. Then they take to a pediatrician. Pediatrician will say this is psychogenic, he's doing wantingly. Then again they go another pediatrician. Again that pediatrician will say no, this is psychogenic only. So once you look at them, you don't need to document that there is a wheeze. No child comes to you, to your office practice with a wheeze. Always child comes to you with symptoms, and when they come to your clinic, there is no symptoms at all.
How to differentiate then, psychogenic and asthma?
So if you have so first is history. So in those children, they'll also have exercise-induced symptoms. So any child who has deep sighing breathing, you please ask them whenever they might not do physical activities because it is restraining them or they're kind of getting tired because of that. But if you just ask them, when you run up the stairs, run down the stairs, when you laugh, if the child sings, if the child dances, Bharatanatyam, whatever it is, you ask them, do you feel breathless? The child at the end will say, yes, I am breathless. And more importantly, allow more than 12-year-olds or more than 6-year-olds to talk. Once you allow more than 6 years and 12-year-olds to talk, because parents always try to underplay the symptoms. Because they don't want to listen to a diagnosis of asthma, they want to undertone the symptoms. And when you ask the child, when you go to school, when you play with your friends, are you able to run as fast as your friend? They say, no, I'm not able to run as fast as my friend. I get cough in between. I stop and become breathless. So those are some clinical pointers that this is wheezing. So apart from that, child can only have daytime cough. So a dictum has been taught to us that child should always have a nighttime cough to conclude as asthma. You don't need to. Children can only have daytime cough. Child will have perfectly normal sleep. Yet child will have asthma. That is where your lung function tests are going to help you. That is where your phenotyping, doing a serum IgE. We've had children coming to us with only deep sighing breathing and serum IgE is going up to 3000s. So you don't need to have florid symptoms to present with severe wheeze. and more importantly, spreads from one person to another person. So that is probably something that I don't need to discuss, because no asthma spreads from one person to another person. So this was something that madam also said. Neither my parents or my family has history of asthma, then now how come my child has it, right? So I just wanted to know what is somebody's perspective here. Anybody can answer. What do you think is your perspective about if parent asks you this question?
Only 30% of the parents may be having the history, and rest of the 70% may not be having a family history.
Sir, history-wise, if a mother has, there is 70% chances the child will get it. If a father has, there is 50% chances. If father and mother do not have it, but grandfathers have it, chance is almost similar, 50%. And that is where we talk about phenotype and genotype, and that is where we start talking about not only phenotypes and genotypes, we start talking about endotypes. So you don't need to have the whole gene getting transmitted to you. The endotypes, that is a part of the gene also gets transmitted to you, can cause asthma. And that is the reason why we tell them that it is very important that you do not need to have a history of asthma. Neither your parents, grandparents, none of your forefathers do not need to have asthma, because asthma is heterogeneous. So diagnosis itself is, definition itself says it is heterogeneous. You don't need to have always a family history of asthma. See, in Bangalore, we have done a environmental study where we have looked at what was the incidence of asthma in 2000 and what is the incidence of asthma in 2020 in children. So in 2000, that is 2000, incidence of asthma was only 5 per 1000. Only 5 per 1000. Now we are seeing 30 per 1000. 5-fold increase in asthma in Bangalore in a span of 20 years, what we have not achieved for 2000 years. And probably you will be able to say, why asthma has increased? Population is the same. Yeah, probably a lot of influx of population is happening. But things have worsened in terms of environment. So we don't ever consider environment. A house within 50 meters of a national highway is going to have severe allergic rhinitis and asthma symptoms, because you are exposed to diesel exhaust. Diesel exhaust has nitric oxide, nitrogen dioxide, sulfur dioxide, ozone. Ozone is a bigger chemical which damages your airways than any other chemical. So when we talk about asthma, it is heterogeneous, and more importantly, environmental factors plays a major role. When we were young, we were never inside our houses. We were always outside. We were playing kites, we were playing those small pebbles, we were playing a lot of other games outside. But now which child is outside? They're always in their mobiles, they're always sitting on their nice plush couches, right? So indoor allergens have increased. So that is the reason why it is heterogeneous. And this is a very important question I need to ask. How about Ayurveda or homeopathy? Madam, you told you will refer. What about others? What do you feel? Homeopathy or Ayurveda?
Fish is there. One fish is there.
Don't use those inhalers. They are addictive and dangerous. These are the advertisements coming even in the paper or TV news, which Ayurveda people or homeopathy, they tell, and that causes a main hindrance or main obstacle.
That we have to do more TV programs, sir. Other than they have the money, they are doing TV programs. We are not sponsoring, so we are not getting TV programs. So, but what will be your perspective? See, as a parent, I'll come to you, I'll ask you, Madam, I have a child, or Sir, I have a child, asthma. You told me this is asthma, I have accepted the diagnosis. But my relatives are saying they are forcing me to go and do Ayurveda or homeopathy. What do you say? So, what will be your answer? What would you say?
I will say that I am not expert in the Ayurveda and homeopathy, but I am expert in allopathy, and this is evidence-based medicine is there. So we have got evidence, we have proven it that it is improved after these steroids. We can show the percentage, and we can show the left is if liver lung function test improving after these inhaled corticosteroids. That we can say them. That is evidence-based medicine is there.
So that is one way of saying, and next day they will be changing the doctor. You keep talking evidence-based medicine, but I am not going to listen to, because my relatives have much more stronger control over me than evidence-based medicine. So usually I am going to present a paper also on that. Please do not discourage alternative medicines. if you discourage alternative medicines, parents are going to change doctors and parents are never going to come back. Never discourage alternative. You want to take Ayurveda? I am not an expert in that, but if you feel your child is going to improve with it, please use. Any alternative therapy is welcome, because alternative therapy usage, so first thing is it doesn't discourage them, because as a doctor we always try to degrade other medicines. The same thing the sir said, Ayurveda is trying to degrade inhaled corticosteroids, which is the only evidence, because there is no head-on-head studies. They are trying to degrade, saying that this is the safest, doesn't have any side effects. But at the same time, if you try to convince in an aggressive way, nahi aapko jana hai to jao, aapko karna hai to karo, they are going to do the same thing. They will go. So you know at the same time that you have to convince them in a reasonable way, in a non-threatening way. You tell them, please do Ayurveda, you please do homeopathy, but do continue giving this. If they consider that will improve their lung functions, let it be. But at least child will be taking the medications and getting better with the medications. If they want to steal the limelight and take the credit, let them take it, no issues. But at the same time, at least they will continue ICS. So that was what I would probably. So the next maximum questions that we usually get, allergen or what can cause. So what do you guys think? Food. Do you personally believe any food causes allergy? No, this is what pediatricians say. Don't drink milk, don't eat curd, don't eat ice cream, don't eat. Now, this is general.
Do come across, especially during this grape season. Many children eating grapes, we come across the wheezing and this. Probably maybe the high amount of insecticides, it is high amount of insecticides used for the grapes. That may be the reason, I don't know. But we definitely see in these 2 months very high incidence of wheezing, coughing and everything.
So how about others?
Few with banana.
Ask them, you observe your child, give all foods. If you came across something, you just stop it for 4 weeks and again introduce. If you are getting recurrent allergy after this food, then and then only you decide whether to stop or not. But you give all foods, and your observation is better than my observation regarding any allergen.
Right. So most important thing is allergy is not association. What we always talk about is only association. It is not allergy. Allergy, you always have to have a certain amount of multisystem disorder. Allergy never causes single-handedly only asthma or wheezing. So that is very categorical. You cannot and you will never have allergy of your airways without causing oral allergy syndrome, gut allergies, skin allergies. So you have a particular food item, you have oral allergy syndrome, I will accept, yes, it is allergy. You have food, you start having loose stools. See, cow's milk protein allergy, even before causing wheezing, it causes a lot of diarrhea, it causes blood in stools, it causes body rashes. Same thing with food also. So no food selectively causes allergies, and if a food is selectively causing allergy, it has to be multi-systemic. You cannot have single system allergy with only food. So for a matter of fact, celiac disease, wheat can cause wheezing, 100%. But it also involves your intestines. It causes a lot of bloating, megaloblastic anemia, child has failure to thrive. Cow's milk protein, probably everybody has seen it. They have loose stools, they have blood in stools, failure to thrive, and then wheezing. So no food specifically causes allergies. And sir said banana. Banana actually increases your lung function by 30%. So please don't ask me which type of banana and all. All bananas have magnesium. But magnesium is loaded in bananas, and that is the medication that we give in acute severe exacerbation. 30% reduction in asthma after eating banana is being quantified in asthma control trials in children, particularly more than 6 years. So there is no reason for us to believe that banana causes any food allergies. And this is a very common question. Can my child drink normal water or boiled water? Isn't it? So anything that is not chilled to 4 degrees, 2 to 4 degrees. So if somebody can tell me, why would chilled water cause wheezing? Chilled water, spicy food, probably older people among here would have eaten spicy food and they start wheezing. GERD is one of them, but without GERD also you can wheeze, isn't it?
So this cold water decreases the blood supply locally due to vasoconstriction.
Locally
And-
is in the mouth, sir?
In the throat, and hence the immunity goes down there. So infection chances are there. And about wheezing, I don't know. And about the banana, I want to tell, sir, the bananas or the fruits over here are they're ripened by chemicals, and that is causing more problem in our patients.
So those
So-
causes lot of other problems, sir. So blood cancers are increasing because of that. So there is a belt in Karwar, coastal part of Karnataka, where there is lot of mining going on, and there's lot of other chemicals because of the port part of it. There is very high incidence of polycythemia in those population. Every other house you go, you'll have one person in the house having polycythemia. So we have other problems happening because of it, but has there been a association with asthma is something that we don't know. So I cannot comment on that, but definitely it doesn't cause, at least for now, there's no concrete evidence for us to say insecticides causes asthma. And fruits wise, no sir. Vitamin C is actually healthy for your breathing pipe because of increased IgA production because of vitamin C. So unlikely that grapes cause. Probably it is coinciding with viral infection season, could be one of the reason. So there's something called as neurohumoral mechanism, which when you eat very spicy food, very sour food, very cold items, your lower esophagus, which is supplied by your vagus nerve, starts secreting lot of chemicals. So vagus nerve, which also supplies your airways, goes into bronchoconstriction because of neurohumoral mechanism. Not directly but indirectly. And that is the reason why people develop wheezing whenever they eat spicy food or cold items. So that is the reason why we try to avoid cold items in children who wheeze, not because it directly goes and causes wheezing. It causes wheezing by neurohumoral mechanism. And children who have asthma, they already have a certain amount of heightened vagus response. In them, this causes wheezing. So it's more of a neurohumoral mechanism rather than a direct mechanism. And immunity and all doesn't do anything, sir. And myths regarding the medications. Steroid is bad. That anyway, steroid phobia I've spoken about. So targeted therapy, madam has spoken vividly in the morning, very negligible side effects. Even if you use the same medications for the next 10 years, you'll have zero side effects. So only side effect that has been documented with inhaled corticosteroids has been very high dose budesonide. So children who have received very high dose budesonide, that is 800 to 1600 micrograms for 1 year for severe uncontrolled asthma, the only side effect was height reduction by 1.2 centimeter. Only one side effect, which was height reduction by 1.2 centimeter at 1 year period. The same patient was stopped medication for the next 1 year. They went back in their height to their peer groups, but more importantly, because they stopped the high dose steroid, they continued to have more severe exacerbations, which led to more height reduction and weight reduction in those children. So when you talk about the actual goal compared to what we are talking about, so actual goal is going to be normal height, normal weight with normal lung health. So if you just tell the parents that we are going to restore normal health and normal height and weight by giving these medications, they'll be much more receptive to that rather than stopping the medications. And more importantly, again reiterating, steroids, even you use low dose for longest period of time that you can remember, it is not going to cause any side effects. And aim of the therapy is never to use it for long. Aim of the therapy is to reduce to the lowest possible dose, which child will be comfortable without any exacerbations, to maintain lung health, and more importantly, to maintain the normal growth of the child is what the aim of the therapy should be. That is what we are going to do. That is the reason why reduction of medication happens in 3 months' time. Steroid causes addiction. So I always tell them, you have diabetes, you have hypertension. Everybody has. So you tell me who doesn't have diabetes and hypertension. Do they start on medications? Yes, they start on medications. Is it? Do they take it for life? Yes, they take it for life. Does it cause addiction? They say no, it doesn't cause addiction. If they stop today, what will happen to their diabetes? Diabetes is going to increase. So once I tell them that diabetes, hypertension and asthma are same. Diabetes is a chronic metabolic disorder. Asthma is a chronic respiratory disorder. Because both chronic is similar to both of them, medicines have to be persisted. So once you tell them that medicines have to be persisted, they accept the persistence of the medication. At the same time, I also tell them that I will stop steroids today. after 3 months of therapy, your child is going to have zero side effects. There's no withdrawal because I'm not giving hashish. I'm not giving ganja to your child. These are well studied, well recognized, and well randomized trials which have proved that steroid causes no side effects. So if you just tell them that, they are quite comfortable with that. And steroid has long-term side effects that I've already spoken about. So cure, this is something that everybody is going to ask you. How will this get disease? Will this disease get cured? Will my child get better by school age? Will my child get better with adolescence? So if there is a parent who has asthma, it's much easier for you. Madam, you have asthma. Have you gotten better by now? So the answer will be no. So if you have your answer, this is your answer. Your child will also be asthmatic, but he will not suffer like you because he's on good medications. If you just say that, she will follow it. Yes, some children will go in for a long hiatus. Like in COVID, 2 years of zero symptoms. After 6 years, they might have 1 or 2 symptoms. But that doesn't mean that their asthma is gone. Asthma will be still there. Exacerbations will come down. If you just counsel them in this line, they will accept it and they'll move on. And more importantly, every time they come, please emphasize word asthma. What they think is after 3 months, patient has not had any exacerbation, patient has gotten better, so asthma diagnosis is gone, so forget about asthma. So please tell, have you understood what your child has? Do you know why we are reducing the medication? Do you understand how to take it forward? If those 3 questions they answer, no, that means they have understood the therapy and they will continue to stick on with you. Now coming to food, the greatest debate, milk mucus theory. So milk causes more mucus production. I think everybody would have come across this, no? Milk, I don't give milk during asthma. I don't give milk to my child only. I restrain milk, A2 milk, buffalo milk, almond milk. They keep asking all sorts of questions. So what milk is better? I've started A2 milk for my child. Is that better for my child? No, from A2 milk I've switched over because A2 milk has a lot of, currently they are mixing a lot of other things with A2 milk. So I've started almond milk. Is that milk better for my child? So again, there is no increased milk production. This was an excellent study from UK. This was a community-based study which they looked at cow's milk as well as soy milk in population between 2 to 5 years, and they found that there is no increase in mucus production, increase in exacerbations or any episodes of asthma. And the same thing was occurred with fruit consumption also. Evidence was that with higher consumption of banana, asthma comes down. And more importantly, apple juice extracts as well as bananas actually have protective effect. So people tell, I don't give apple to my child because child starts wheezing. I don't give banana to my child starts wheezing. And more importantly, complementary medicine. This is extremely important. Please don't discourage and don't be combative, because initially in my practice I was. If somebody would come and tell me, say, ask me 10 years or 12 years ago, I would say, you do whatever you want to do. Don't come back to me. I would say that. And they would not come back to me. They would come back to me after 6 months, 1 year, saying that my child's wheezing has worsened. So can we continue this therapy? Then I would retrospectively start thinking, if I was not that combative with them, probably if I had just counseled them, please do Ayurveda, do homeopathy, but please do persist with this medication also in a reasonable way, they probably would have continued the same medication. And I've seen children's lung function dropping from say 80s to 60s also, because they have not used, and child had continuously significant symptoms. So with this, I'm going to end my talk. I would want the esteemed audience to have a little bit more discussion on this, if there is any.
One question. One question. Whether the fast food, it is consumed in a large quantity by the new generation. So whether the color, chemicals and additives which are there in the fast food, so whether they are hazardous and can they exaggerate wheezing?
100%, sir. So whenever I counsel, I only counsel them to avoid only these items. Very sour food. So if you feel a food is sour to you, it is sour to your child also. And if your child is eating very significant sour food, because of the neurohumoral mechanism, child is going to wheeze. Same thing with chilled items. Anything that is directly taken out of the refrigerator and drank will cause neurohumoral mechanism and wheeze. And anything that is very spicy, anything that is given very spicily, particularly children these days are very fond of biryanis, particularly in south part of the country. Everybody loves biryanis. And particularly some types of biryanis are so spicy, still children want to eat it, and there will be a wheezing. So that's one part of the food. The second part of the food is always going to be MSG, monosodium glutamate or Ajinomoto, that is used in food to make it very tasty, which is part of all fast food, is known to cause wheezing. So we always tell the same to the parents. So children are fond of eating Maggi, children are fond of eating a lot of ketchup. We tell them that MSG is going to increase your wheezing. Apart from that, like Sir said, colored items, chemicals, colored items which are there in your food as preservatives can increase wheezing. So these are some of the things that I usually tell them not to eat, and more importantly, tell them wait until your child's wheeze gets better. Then you start him on whatever you want, child will be better. When your child is coughing, you give water, child will cough. So do you want to still stop giving water also? That is not going to happen. So please stop all the items for now. Wait until your child gets better in a week to 2 weeks time. Then you restart. You will come back and tell me your child is able to eat ice creams without having any discomfort. So that is what I usually do. So if there's anything that anybody else is doing.
Regarding pets in the house.
So that is definitely no, sir. If you already know a child has asthma and child has symptoms because of asthma, we always say no. Of the cats and dogs, cats are the even worst. So cat danders, if just comes inside the room, ruffles its fur and goes outside, the cat dander stays in your room for 9 months. So cat danders are the worst. So we say no to cat danders. We say no to hamsters and lot of pigeon droppings. A lot of people have habit for rearing lovebirds, cockatoo, all those things. Those can cause hypersensitivity pneumonitis. We have had children coming to us with chronic HP, where the only treatment is going to be lung transplant. So we always say. And always when you're dealing with asthma, comorbidities. Always look for comorbidities.
Sir, in
Many times parents ask about food or any allergen testing. Like, should we go for allergen testing, which are actually very costly. So, in what cases should we recommend, or is it?
If you are 100% sure that it is a food allergy, you go for food allergy. But most of them, it is association. It is never allergy. In India, I have not seen even a single child coming with peanut allergy. I have only seen it in children who have come back from US. That is second generation people where parents have migrated but their children have been born there. They have come back with peanut allergies, but none of our Indian kids. So that's the reason where I trained, my professor used to say Asian genes are the most strongest, because we don't have such common diseases that the West finds. We don't have cystic fibrosis that commonly. We don't have PCD so commonly, even though we have it. We don't have asthma so severe. In UK, you just need 2 minutes for ambulance to arrive in your house. That is the only time that they give. If it lands after 2 minutes, the paramedical workers can be taken for task, because that is the severity with which they live there. Very uncommon, sir. And like I said, cow's milk protein allergy first involves your gut. So if the child has gut symptoms, then only I start thinking about. If, yes, see, we have seen rarer things also. We have seen dals causing asthma. Mother has specifically looked at tur dal, moong dal. When she's given it, child has wheezed. Every time she gives it, the child has wheezed. And we have done food challenge test for that, and child has had very big hype for it. So there are case reports, there are incidences. I am not denying there are not, but 99% of the times there is no food allergy, at least for as long as.
So this patient wheezing with neurohumoral mechanism, if such patient comes to us, what will be the treatment?
So it will still continue to be ICS, but you are going to continue avoiding those food items. But at the same time, if the child has comorbidity as GERD, then you have to treat the GERD. Thank you.
Thank you, Dr. Shikanta sir. About that neurohumoral mechanism है ना, for I don't know about kids, but adult के लिए तो avoidable है. So long breathing. So this is on lighter note. as I belongs to Art of Living family, long breathing exhalation stimulates the vagus nerve. You are living in the Bangalore, then Art of Living ashram is there. So long breathing stimulates scientifically the neurohumoral and it calms down the vagus nerve. So your neurohumoral mechanism would not, if any adult is suffering from that. Yes, and second thing I want to give one ICS के लिए. So that is a mask, snugly fitted mask वापरत नहीं सगळे. So that counseling is very important. Whatever ICS dose you use, that snugly fitted mask is very important. So that is because lot of patients comes with me and all pediatricians write ICS correctly, but they're not seeing that that is mask is snugly fitted. So that counseling one tip is very important. So for the next very exciting panel discussion is going to be there, 45 minutes. I invite for that very enthusiastic, dynamic, my friend Dr. Rajashri Meru. She has done her UG and PG in Mumbai and the director of Span Critical Care Center also as a moderator. Welcome Rajashri. And also I welcome Dr. Shrikanta sir again for the panel discussion. You can have a seat over there, sir. इथं थांबूनच करायला लागेल तुला. हां इथंच आहे ना तो तर. हां. Second panelist is Dr. Abhay Patil sir. He has done his UG from Latur and PG from VM Medical College and practicing since 16 years. He is ex-president IIP Dharashiv. Dr. Abhay Patil sir, please. And Dr. Mahesh Arkal. He is eminent pediatrician, everybody knows. I welcome you for the panel discussion.
Hello, good afternoon everyone. First of all, I thank Dr. Pratibha and all the office bearers of Solapur IIP for giving me this opportunity. We are really fortunate to have Dr. Shrikant sir as a panelist. Sir, your both lectures were absolutely fabulous, and especially the first lecture, we all had really academic feast for our eyes as well as ears. So let us grab few more knowledge as much as possible from Dr. Shrikant sir. So I welcome my colleagues, Dr. Mahesh Arkal and Dr. Abhay Patil sir. So first of all, when Shrikant sir was discussing all the bronchoscopy cases, which he has fabulously treated, for a second there was a thought in our mind, especially in my mind, what are we practicing? Like these cases which sir was explaining were really very difficult and challenging cases. But whatever cases we will be discussing now is our daily bread and butter cases. They are commonly seen in our day-to-day practice. Most of the things we will be discussing is community-acquired pneumonias. But in that also tuberculous pneumonia and other fungal and opportunistic pneumonias will take a different session. So more of we will be discussing community-acquired pneumonias. So coming to the global thing, we all know it's a global burden to all of us. It is one of the leading cause of death for children under 5 years, and also the mortality, India along with other developing countries is contributing a lot towards increasing the mortality. More than 50% of the deaths are seen in these developing countries. So we can understand what is our role. The WHO has already decided to decrease this load by less than 3 per 1,000 birth, and it's our duty as a pediatrician to achieve this goal as early as possible. So every 13 seconds we are losing a child with pneumonia, which is not a good news for all of us when we are saying that everything is developing, but we are losing a child. So definitely it's a serious topic. So as I said, we will be discussing common cases. So first case is to Dr. Abhay Patil. He is a 15-month-old child who came with fever, cough and cold since last 5 days. Mother is very apprehensive because the child is having fever since 5 days and child is coughing also. So my question is, on examination child is fresh, all the systems are normal. So is there any need of any investigation what is the role of oral antibiotics, cough syrups, and nebulization?
The child age of the child is
15 months.
15 months. So 3 to 5 years. Baby is playful. Baby is playful. Only fever, cough, cold.
Yes.
So we should not go for investigation.
Right.
Just reassurance.
Right.
And if the child is having fever, only paracetamol, feeding,
Symptom.
adequate feeding
Yes.
will suffice.
Yes. So adequate hydration, and paracetamol and symptomatic management. What about cough syrups, sir?
So no. We should not
Okay.
go for cough syrups.
Right.
Because most of the cough syrups contains bronchodilator, they cause irritation in the baby.
Right.
Even nebulization can cause irritation,
Right.
tachycardia.
Right. And
Arrhythmias can cause arrhythmias also.
right.
So
Right.
no to cough syrups.
Right,
We should
and
not
we all know that there are many incidences of death with the cough syrup. So as much as possible, we should avoid giving cough
to
syrup.
dextromethorphan is
Yes.
no to dextromethorphan.
Correct.
Less than 2 years.
Right. So my next question is, when to follow up? What are the things where you will tell the parents to come?
Ask them to come for follow-up after 48 hours. If the
Okay.
child is having fever, playful child.
Okay. Yes, sir.
Only reassurance.
Right, sir. Thank you, sir. So my next case is to Dr. Mahesh Sarkar. He's a 2-year-old child who has come with fever, cough, cold, but this child has breathing difficulty. Mother is noticing that child is not taking feeds regularly and there is breathing difficulty also. On examination also child is sick looking, that is tachypnea, nasal flaring, SpO2 is bit hypoxic, between 90 to 95 on room air. Clinically child has wheezing and crepitations, all the systems are normal. After stabilizing the child, we got done his basic investigations where WBCs and everything was normal except some few lymphocytic predominance in the CBC and slight low in the lower platelets, and CRP was 20. We got on his X-ray which showed this picture. So what is your opinion and how to go about this case?
Presently, baby is presented with fever, cough.
Yes.
It is it shows many warning signs. There is difficulty in feeding. Baby is dull,
Right.
taking feeds. It is infective. Is
Etiology.
there. We have to see for the viral or any bacterial infection might be there.
Yeah.
We have to hospitalize this baby and start the proper treatment.
Right. On the X-ray also we have seen there is hyperinflated chest with hilar filtrations are more. So this is a case of viral pneumonia where on the X-ray we have seen bilateral interstitial opacities and peribronchial thickening. So it's a case of viral pneumonia. So what would you advise as medicine for this child, apart from initial stabilization?
In viral pneumonia,
Yeah.
there is no definitive role of any antiviral medications.
Right.
Depending on the age of the patient and cause of the
Disease.
presenting illness with any organism involved, we can start the antiviral on the basis of that. If it is baby is sick and any comorbid conditions presenting with fever, breathlessness, we can join this with the secondary bacterial infection. We can
Right.
think of starting the
Primary.
anti-primary first-line antibiotics.
Correct. So regarding BioFire, Sandeep sir has detailed given explanations, but just a quick take up by Dr. Shrikant sir. So when should we do BioFire test and how should we interpret it?
So just before, so if we see the child, so I probably think everybody here is well versed with 2018 WHO guidelines on pneumonia. So we don't have those 4 categories now. It is no
only
pneumonia,
2.
pneumonia and severe pneumonia. There is no category. So this child comes into severe category. So child requires hospitalization. And more importantly, child required just IV fluids if the child is sick, not able to feed. And more importantly, a supplementary therapy, probably HFNC if child is very tachypnic, or more importantly, will this child require a BioFire is a very important question. Yes, definitely this child will require BioFire because, see, I am a realist. I am not going to talk to you. I will use only amoxicillin. Amoxicillin is the drug of choice for. So please tell me which pediatrician here uses amoxicillin for simple pneumonia, even now. Amoxicillin only. plain amoxicillin, not even a single person. But whenever we sit in a conference, we always talk, we become realist. So I'm not a realist, but what I'm going to say is, yes, any child who comes to your center and has features that was presented currently, please kindly try to get a biofire done. Because you starting augmentin, you starting ceftriaxone, because ceftriaxone is the probably the best antibiotic world has seen, isn't it? Everybody uses it, and everybody as you abuses it also. So get a biofire done. You get a report in 6 hours. Only 6 hours. Within 6 hours, you are able to decide should you start antibiotic or not. Until unless child is not in shock, child is not septic, child doesn't have clear-cut signs of consolidation, you don't need to start antibiotic. But again, it depends on center to center and where you work and how well equipped your centers are, because a child is such sick, seldom any pediatrician will not start antibiotic, isn't it? So in this particular child, that is where your biofire is going to help, and more importantly, tailor-made biofires are going to be the futuristic investigations of choice. 8 viruses, 10 viruses, tailor make it for yourself. You have companies which will come to you, ask you, these are the viruses that we provide you. What all do you want? You tell them these are the viruses that I want. Tailor make that particular cartridge for me, and I will send you the samples. So send all the children who have at least gotten admitted into your centers for viral infections, and it is going to value add to your system, and more importantly reduce the burden of antibiotics on those patients, and it is going to be a way forward in antibiotic stewardship. You can actually start putting out in conferences that this is what you are doing in a small center, and taking forward the antibiotic stewardship as a major success in your center. So that will be an excellent thing.
Yes, yes. So basically, role of biofire is to avoid extra antibiotic abuse. One more thing I want to ask. Sir. Yes. Mic.
So again, back.
Because there is pneumonia, so it may be staph or influenza, anything else. But definitely viral, it is okay. For upper and lower, the same virus is there. But how far it is sensitive for bacterial pneumonia? Because BAL, I agree with the BAL for a bacterial infection. It can be directly points out the pneumonia. For upper respiratory.
So that is a very good point. So you have a consolidation. You have a patch on the X-ray, and child has pneumonia.
Mixed picture, basically.
So proper bacterial pneumonia. You know it is bacterial pneumonia. In those children, do a induced sputum. So do a induced sputum, and that induced sputum you send it for this particular testing. If a child is able to induce sputum, you can even plate it for cultures also. But cultures will take 3 to 5 days time. And before that, you need to understand what bug it is. So that is why this is going to help. In induced sputum, sensitivity is as high as 93%.
So I wanted the same thing, because they just do the swab. Exactly. But for bacterial, it has to be induced sputum.
See, for Streptococcus pneumoniae, 60% of everybody here will have nasopharyngeal colonization. So even if I do one now, I will have Streptococcus pneumoniae positive. And mycoplasma also. So induced sputum will be better.
Now the induced sputum in case of 6 months old baby is difficult. So gastric aspirate can be used in this case.
Absolutely. In those children, even gastric aspirates can be done. But the only thing is sensitivity and specificity because of digestion. It is not tuberculosis. It is not acid resistant.
Right.
So these are all acid sensitive organisms. So acid sensitive organisms will break and it will get digested. So in gastric lavage, getting these bugs will be that much more difficult, whereas in induced sputum, see, child doesn't have to cough out. If the sputum just comes up to the upper airway and child swallows, the bug is left in the airway. So it increases your sensitivity and specificity. So rather than just blindly doing an nasopharyngeal swab, do a 3% hypertonic saline neb, let the child cough because of the airway irritation, and then take a swab. Just coughing alone can be used as a surrogate marker for you getting a diagnosis of particular bug.
Okay, sir. So one more thing, I'm sure all the audience, especially the senior pediatricians in the crowd, will agree that recently, since last few years, suddenly there is rapid surge in the viral pneumonia cases. What we have seen recently as a flu season till March. So previously, like before 1 or 2 decades, I'm sure this was not there. So what could be the causes for having such a rapid surge? Is it because of changing dynamics of the pneumonias in the world, or is it because of increased population or pollution or what? Like,
We are,
what's it?
so are we talking about pneumonias? Or are we talking
Viral
about
pneumonias.
viral
More of
pneumonias?
incidence of viral pneumonias are
Right.
increasing.
So viral pneumonias has actually increased in the last 1 year only because of 2 years of COVID. So,
Okay.
so the plausible theory that has been suggested by everybody is because they have not been exposed to viral infections, and because everybody stayed at home, they did not have any flu vaccinations. At least the vaccinations kind of got postponed, or a lot of people did not ever venture out. There are families which have not come out of their houses for 2 years. So in those scenarios, yes, your immune system gets blunted because you are as sharp as you are exposed to. If you are not sharp, then definitely your immune system goes down. And particularly between 3 to 6 years and beyond that, microorganisms have to be a part of your system. If you do not get exposed to microorganisms, you will not be able to mount a response, and that non-mounting of response definitely has caused this. Again, coming to why have we seen such severe pandemic kind of a incidence of adenovirus, that nobody has an answer. Everybody keeps plausible theories, COVID.
Or maybe we are diagnosing it because of these newer tools, or
That is
Increasing diagnostic modalities.
That's what I
and
said.
we are more aware about the diagnosis of respiratory
Correct.
viruses.
But more importantly, have the virus become more virulent?
Yeah.
Probably yes.
Right.
Have the immune systems gotten blunted because of no exposures to infections? Probably yes. But again, has COVID caused any mishap with our immune system? That's the
We don't
only
know.
plausible theory
Right.
which actually supports. Because have we found any reason for MISC to happen until now?
Correct.
No.
Yes.
Have we found any possible virus for Kawasaki disease happening until now when COVID started happening?
This
We
is
were
it.
actually contributing everything to COVID only, and we were positive. So 4 to 6 weeks after COVID infection, child was coming with MISC. So MISC has caused lot of symptoms which we still do not understand. That is the reason post vaccination people have developed neuropathies.
Yeah.
People have developed myopathies, people have post-COVID syndromes. So we do not know. So that is definitely being looked at in a lot of Western literature. But until we concretely tell, these are the three possible theories: COVID, no infections, and no, definitely, virulence of the organism.
Okay. Thank you, sir. Thank you for that elaborate discussion. Now coming to the fourth case, Dr. Abhay Patil is a 8-year-old child who came with history of fever since 5 days, cough and sore throat, and child was also complaining of chest pain. On examination, child was febrile, sick looking, tachypnea, and SpO2 was between 90 to 95 at room air. On auscultation, child had bronchial breathing on the left middle and lower zone, and other systems were normal. We got on his investigations which showed WBC of 20,000, and rest all of the things were normal except high CRP. His X-ray was like this. So what's your opinion?
Backside. From history, child is having fever, sick looking child, and
Yes.
there is a bronchial breathing.
Yes.
Itself, there is a consolidation on mid and
Yes.
lower zone, left
Yes.
side.
Yes.
And WBC is 20,000 with
Right.
CRP high. More
Yes.
goes in favor of bacterial pneumonia.
Correct, sir. So,
Chest X-ray is also showing consolidation.
yes, there is a consolidation in the left middle and lower zone. So, can you please tell us the etiopathogenesis of bacterial pneumonia or oral pneumonia?
Difference, age-wise difference. There is a less than 3 months Klebsiella, E. coli, pneumococcal pneumonia, staph, and more
Right.
than 5 years. Less cases of staph, but pneumococcus and H. influenza.
Right. From 3 to 5 years?
3 to 5
This-
years pneumococcal, H. influenza and staph aureus.
Right. So this is the various pathogens which we are coming across, and I would ask Dr. Mahesh Arkal regarding the antibiotic choice and the therapy of bacterial pneumonia.
If child is sick, and we should go to the whole blood culture and
Other test.
other test, and we start the first line treatment with the amoxicillin and ampicillin, whatever is the age accordingly, and
Right.
with the second line we will start the cephalosporins and
Right. Right. So this is the treatment which IIP respiratory module is explaining us, and according to that, we have to treat the child. Even they have mentioned the duration also. Depending on the severity of the disease, we have to increase the duration of the treatment. No, so the basic principles of treatment is all children with diagnosis of pneumonia should receive antibiotics. Any child who is less than 3 months should be hospitalized and taken injectable antibiotics. Oral route is preferable only if the child is not having severe pneumonia. So this is also very commonly seen cases in our OPDs or IPDs where child is clinically not looking very sick, but parents are not happy. I mean, especially mother tells that he is coughing, there is a fever, and auscultation, there are crepitations, and even on the X-rays we can see that lower zones there are patches and signs of consolidations. So we are treating it as atypical pneumonia. On the serology also it has proved. So I want to ask Dr. Shrikant sir, kindly tell us about atypical pneumonia.
See, anybody presents more than 5 years of age, atypical always has to be thought as one of the commonest causes of pneumonia. But there should be some amount of incongruence between your clinical as well as your, that is, you should have a certain amount of difference. So clinically, child is happily running around, playing around, and still has bronchial breath sounds. Definitely there is incongruence. Or child is sick, but X-ray is not showing that it is sick. Definitely there is incongruence. So there is clinical radiological incongruence. You always start thinking about mycoplasma infection. But again, if you look at evidence currently in all of South Asia and Southeast Asia, azithromycin is resistant. That is, mycoplasma is resistant to azithromycin in 90% of children. 90. So we using azithromycin right, left and center is definitely not something that is going to take us anywhere.
Injectable, sir? Sorry to interrupt. Injectable
Anything,
azithromycin?
madam. Okay. Even azithromycin injectable or oral, it is resistant.
Okay.
For a matter of fact, amoxicillin is still sensitive. Not for mycoplasma pneumonia, for streptococcus pneumonia, but mycoplasma pneumonia, because you had COVID, everybody used azithromycin. You had viral infections, everybody started using azithromycin. So azithromycin has become resistant. So we use it, probably it can do a little bit of anti-inflammatory property, but as a mycoplasma infection, does it do anything? Absolutely no. More importantly, if the child is sick, anyways you're going to treat the child with azithromycin or clarithromycin. If azithromycin, clarithromycin is not going to function, you're going to go to macrolides. That is, you're going to go to fluoroquinolones, that is ciprofloxacin or levofloxacin, or sometimes you might even go to tetracyclines. But more importantly, azithromycin is becoming more or more antibiotic of bygone era. And investigation wise, more importantly, you can do some basic investigations in these children. So CBC might be not something suggestive of, but LDH is something that you can do definitely. LDH and mycoplasma infections are always elevated. So that is a very subtle sign of these particular children. And again, incongruence between chest X-ray and the child. Child is otherwise happy, but there is significant hypoxemia. Child has severe hypoxemia, but child has a patch, doesn't have a patch. Child has a patch, but a significant patch, but child is absolutely playful. So this has to be there for you to call it as mycoplasma. Just looking at the X-ray, please don't label it mycoplasma. Just looking at the child, don't please label it as mycoplasma, because there should be certain amount of incongruence in your symptoms. And please don't start azithromycin because it's a self-limiting disease. You don't do, child will get better within 3 to 5 days. You do, child will get better within 3 to 5 days.
Okay, sir. Thank you so much. So conclusion, we have seen 3 cases. The first case, viral pneumonia, where it follows with short URTI. There is gradual onset. Child is less toxic. These may be associated. Sometimes they may mimic like bronchiolitis. And usually viral pneumonias are affecting bilateral, and they last for 3 to 5 days, and they resolve spontaneously. In bacterial pneumonia, most common I have just enlightened, staphylococcal and streptococcal, where they are very toxic, they are rapid in progression, they present with lobar pneumonia, also they have GI manifestations, and in complication wise they show all these empyema, abscesses, necrotizing pneumonia as well as nematocele formation. While atypical pneumonia, sir has already told, they look like more viral pneumonia, wheezing may be there or may not be there, and more or less it is like a walking pneumonia, we call it as. So hospital acquired pneumonias are seen within 48 hours if the child gets pneumonia, and these are the drugs which can be used for hospital-acquired pneumonia. So coming to the next thing, that is, what are the, Dr. Abhay Patel, what are the factors which affect the recovery in a child in a case of pneumonia?
Factors is age is the factor. If the age of the child is less, recovery will be slower. Nutritional, if the child is malnutrited, then again it will hamper with the recovery. Immunization status, if there is a immunodeficiency, either primary or secondary. Secondary immunodeficiencies may develop with prolonged use of steroids, child on anti-malignant drugs. They will have slower recovery.
Yes.
And socio-demographic status, low socio-economic status will have poor recovery.
Right. And especially after regarding vaccination, we want to highlight, especially after giving pneumococcal vaccines, especially in Europe, the pneumonia incidence has reduced dramatically. So vaccination we should encourage to all the kids, especially flu vaccine and this pneumococcal vaccination. So
just to add on,
yes.
Can somebody tell me what is the uptake of pneumococcal vaccine in India? Anybody?
Less than 25.
Madam?
Less than 25% maybe.
It's only 7%.
Yeah, less than 25%.
So if we have 100 children, only 7 children are getting pneumococcal vaccine. So that is the level of coverage. So that is the reason why we are seeing severe streptococcal pneumonias in unvaccinated children even now. But at the same time, we are also seeing a lot of vaccinated children, all 4 doses, 6, 10, 14 as well as 15 months vaccinated, coming back with very severe pneumonias. Probably if I don't know if there was a very big outbreak of streptococcal pneumonia, at least in Bangalore, where empyema, pneumatoceles and necrotizing pneumonia were more associated with streptococcus pneumonia than staphylococcus aureus.
Okay.
So yes, in 80s, 90s, measles were high, people were developing a lot of staphylococcus aureus pneumonias leading to all those complications. But now more of urban population is developing all the complications because of this. And any child that where we have put our fingers on has had necrotizing pneumonias. Necrotizing pneumonias, of which a couple of children have even undergone a lobectomy.
Yes.
So now staph aureus is not the cause, at least in urban population, particularly vaccinated population. And there comes the reason, yes, inadvertent use of antibiotics is causing these bugs to become resistant. Second, virulence is changing because the strains which are not covered in the vaccine, particularly 33, currently that is the one which is causing, that is becoming not only antibiotic resistant but also becoming more. So you give ceftriaxone, children are not responding. You give piperacillin tazobactam, no response at all. You go to even higher antibiotics like teicoplanin, clindamycin, linezolid, then only they start getting better. So they have become so severely
resistant,
and that is purely because of no vaccination and inadvertent use of antibiotics. So better we start vaccinating everyone and reduce overexposure of antibiotics, particularly in viral infections.
Yes, thank you, sir. Now coming to the next, that is complicated pneumonia. We always see that despite of taking proper interventions, giving proper supportive therapy, child still deteriorates, especially in the second week. Or sometimes child is intervened late and now the child has come with lots of complications. So I want to ask Dr. Mahesh Arkal, what are the signs and symptoms and how do you recognize complicated pneumonia?
These complicated pneumonia are more commonly in some neurological conditions, patient with epilepsy, cerebral palsy. These are more morbid conditions. They are because of poor hygiene and poor health care. They are more affected with the bacterial and viral infection. They are presented with the more complicated than other babies. In other condition, I will see that those who have known case of congenital heart disease or complex congenital heart disease, they are more prone to this infection and they are presented more severe than normal patients.
Correct. So these are the various symptoms child can have, and even we can notice that the symptoms have increased a lot. And so locally they can be seen as persistent pneumonia, effusion, empyema, abscesses, pneumatocyst, and systemic wise there is all these complications we see very often. So how do you diagnose or what are the symptoms of severe pneumonia? Just now we have discussed, but these are the symptoms where child will come with, especially
what we have to tell parents or relatives that child who is not taking feeds properly, if there is a refusal of feed, grunting, cyanosis, vomiting and lethargy, they should be taken treatment as early as possible. These are the red flag signs. So Dr. Abhay Patil, would you like to tell what are the red flags? And we have discussed already, but
General signs related to respiratory system and related to CNS. Poor feeding, decreased oral intake and refusal of feed, severe malnutrition, underlying chronic conditions and head bobbing. These are general signs. Related to respiratory system, increasing RR, grunting, cyanosis and chest indrawing. Related to CNS, lethargic, unconsciousness and convulsions. These are
yes. Thank you. So before discussing the management of severe pneumonia, there is a few X-rays we will be taking to all the audience, especially PGs are supposed to tell these X-rays. So this is one X-ray where you can see thick cavity with a collection inside on the right middle or lateral side of this X-ray. What is it? Anybody, especially PGs? Okay. It's a case of lung abscess. You can see the thick wall along with inside there is a fluid filled in the cavity. It's a case of lung abscess. This is very common and very oftenly we see. You can see there is collection in the right side and obliteration of CP angle. What is it, Pranita? Yes, it's a collection, you can tell effusion or it is basically empyema. Now this is a child who has come with initially viral, presented as viral pneumonia, but despite of treatment the child has progressed and you can see baseline consolidation. So it is, what is it? Viral infection with superadded bacterial infection. So bilateral basal consolidations. Now this is again, child has come and on the X-ray there is a thin wall with a collection inside. Yes, nematocele. And this is, as sir said, we have seen very often, especially post-COVID era, child has come with pneumonia, but despite of treatment, the second X-ray has flared up and clinically also child has deteriorated and we can see the consolidation is increased, infiltration have increased and you can see the necrotizing things in between. What is that? Yes, necrotizing pneumonia. And this is what we see very often in PICU. Despite of treatment, despite of all the supportive management, some of them land up with this whitewash lung or reticular pattern ARDS, right? So now coming to the management, the triaging is very important. Before that, I just want to say about triaging. Triaging is a word which has come after Second World War. There were a lot of victims and a lot of soldiers were injured. So to segregate them, this word was used and they used to sort out like which soldiers need urgent therapy, they were sorted out differently, which one need moderate therapy and which can be seen on day-care basis. So that way the term triage has come and it plays a very important role as far as management of pneumonia is concerned. So I want to ask Dr. Shrikant sir, what are the steps of triaging, how do you go about it and what a pediatrician should see at a referral level as well as at the facility level?
So if you are working in a PHC or a CHC, it is always better when you start them on therapy because at PHC level you are not going to get ceftriaxone. Yes. At PHC level you are not going to get. So first and foremost you always look at, so there are classifications for pneumonias. Right. No pneumonia, pneumonia, severe pneumonia. So no pneumonia has general signs, has respiratory signs as well as other features. So depending on that, there are grading systems now. So grade the child. If there is pneumonia, start them on antibiotic and ask them to come back in 24 to 48 hours. If there is worsening, please refer. If there is no worsening, continue the antibiotic. So there was an excellent study done in Pakistan where 3 days of amoxicillin, only 3 days of amoxicillin was able to cure at least 70 to 80% of pneumonias without having to refer. So that is what amoxicillin does. So again, before even I get it, get the child with pneumonia, they would have already on multiple antibiotics. So I'm not the right person to comment on amoxicillin. But my previous boss, probably you would have heard about him, is Balasubramaniam from Chennai. He still uses amoxicillin. Child comes to him, he first diagnoses the child, he still uses IV amoxicillin as the first line of therapy. Apart from him, I have not seen even a single person using it. And again, triaging, if 24 to 48 hours child is sick, you have to refer. If the child is not sick, you still continue the oral antibiotic, but again ask them to come back in 48 to 72 hours. If child is getting sick, please refer. Refer to a center where they are able to handle the child in terms of ventilation, intubation, ventilation, and more importantly, at that particular juncture, put an IV cannula, give the first dose of IV antibiotic and send them. So any sign of sepsis, any sign of shock or any sign of hurried respiratory breathing, that child has to be referred. I'm not...
Great. This is just a gross because it is very difficult to discuss each and every case in detail. This is just a gross overview what we can do as a pediatrician at facility level and at referent level. Only, as sir already has said, we have to just differentiate whether it is a severe pneumonia or non-severe pneumonia. And how do you diagnose this? Is any child who has come with fever, cough and tachypnea, but there is saturations are within normal limits, then that is a non-severe pneumonia. Where a child who has come with fever, cough, cold, tachypnea, but child is hypoxic, it is non-severe pneumonia. So there is, we don't have to be bogged upon by all the, to learn all the types of pneumonias and label them and all that. Just as a clinical pediatrician, we should remember, is the pneumonia severe or non-severe? That's all. But definitely, before 3 months, we should be really particular in treating. We have to give antibiotics and antimicrobials as early as possible to any child who is coming with pneumonia below 3 months of age. Between 3 to 50 months, 59 months, bronchodilators and other supportive management along with antimicrobials should be done. And facility level we have discussed already. Now, coming to the oxygen delivery system. As we all know, the treatment of pneumonia, oxygen delivery plays a vital role. So, I want to ask Dr. Mahesh Arkal, what are the various oxygen delivery systems which we use?
Basically, we use according to severity. The two non-invasive and invasive modes are there. In non-invasive, you can use the nasal cannula, simple oxygen mask is there, and high flow oxygen system in an infant who is not maintaining with the saturations, and baby is becoming hypoxic, and those patients we can use the high flow nasal. And in another conditions we can use the CPAP also.
Correct, sir. So I want to ask Dr. Shrikant sir. HFNC is playing a vital role in treating these pneumonias. We have also seen that their incidence of taking them on ventilator is also reduced. So what is your take on it, sir?
So when I was trained, HFNC was not in fashion, but NIV was definitely in fashion. So a lot of children were started on NIVs, and NIV was able to take away the invasive ventilation quite significantly. But advent of HFNC, particularly the high flow HFNCs, have led to not only reduce so in our center we don't intubate any child for pneumonia. For matter of fact, there is no child getting intubated. Now the only indication for intubation ventilation is road traffic accidents in our center.
Great.
So that is the level of work that HFNC has been doing, and every child, no matter how significantly distressed, once you start them on HFNC, depending on how severe it is, the flow is adjusted. But once you start them on HFNCs, their symptoms, their effort breathing and their PCO2s as well as O2s also start getting better. And like Madam has said, HFNC has revolutionized the non-invasive ventilation, and we also from NIV, mask and BiPAP machines, we have moved over to more of HFNC. And it's available from as small as neonates to as big as 18 years without having comforts. And even in adult population, HFNC is being taken as a major modality of non-invasive ventilation, and only where they want a more amount of carbon dioxide to be washed out, particularly the type 2 respiratory failures of COPDs, they prefer putting them on mask ventilation rather than HFNCs. But otherwise, HFNC has definitely made a lot of difference.
Okay, thank you. Mike.
Absolutely. So initially you trial them again with HFNC. So basically you're delivering 100% oxygen and trying to reduce their oxygen, their respiratory effort. So by reducing their respiratory effort, delivering 100% oxygen, if you are able to tide off a major intubation ventilation, particularly what we have seen is in compensated shocks, not in uncompensated shocks. Uncompensated shocks has to be intubated, ventilated, because you need to completely paralyze their respiratory system so that you can take control over of it. Because you delay intubating in uncompensated shock, you will never get a chance to again re-intubate them. They will just have significant amount of hypoxemia and they can have significant amount of endotracheal bleeds, lot of DICs. But in compensated shocks, that is the best way of ventilating them, that is non-invasive ventilation, and it has made intensivist jobs very easy.
Right, yes, sir. Even cost of a ventilator machine is very high and HFNC is just around 3 lakhs. Exactly. I think every pediatrician should have in their, not even in wards also, I mean high risk category for.
So if they have HDUs, definitely in HDUs and definitely in all the PICUs.
So moral of the story is we should budget ourselves so that we can have as much as HFNC in our hospital. So to summarize so far, as we discussed already, WHO has now classified only 2 pneumonias, that is non-severe and severe pneumonia. And malnutrition and pallor, they are the very, what you can say, red flag signs for recovery of pneumonia. So any child who has come with malnutrition, the chances of mortality due to pneumonia are very high. So treat them aggressively and as much as early as possible. So in a nutshell, the same things which we have already discussed. So only thing regarding X-rays, when they are added with the signs and symptoms, they will greatly increase the sensitivity and specificity in pneumonia, because ultrasound and CTs are there, but they need expertise opinion. But being a pediatrician, at least we should be able to read the X-rays and correlate it with the clinical pathological symptoms and try to treat the patient along with the serological reports. So predict severe atypical pneumonias as early as possible to have a better outcome. Risk factors we have discussed. Now coming to the supportive management, Dr. Mahesh Arkal, along with oxygen therapy, antibiotics, just a quick answer regarding the management of complicated and supportive.
We find out the cause, it's a viral bacterial. Again, we can go to the organic cause, like gastroesophageal reflux. We start with the antiemetics and reflux pathology, and we can give the position and everything. And we treat the primary cause in the cardiac cases, like as we early closure and solving the cardiac diseases.
Right. And of course the nutrition, that also plays a great role, because what they say is undernutrition is a silent killer for pneumonia. So nutrition part also should be taken care very well. So coming to this case, it's a last case. I know everybody is rushing for the food. It's a last case. So this child, especially for sir, this case we want to discuss. This 8-month-old child, this child had come to us with history of high-grade fever, cough, and severe respiratory distress. He came into our emergency room with severe hypoxia, grunting, and cold extremities. We had to initially stabilize him according to the PALS guidelines, and clinically the child was febrile, intercostal retractions, hypoxic, feeble pulses, dehydration was there. All the systems were normal. So after stabilizing, we got on his investigations where CBC showed counts of 28,000 with polymorphic predominance, I forgot to mention, and platelets and everything was normal. CRP was 46. This was his X-ray, where you can see that there is hilar congestion on both the side. Along with that, there is opacity on the right upper and middle lobe, which is a sign of consolidation. On history, child's birth history and family history was normal, but he has given history of previous hospitalization twice for the same complaints in the hospitals. Means within 6 months, this was his 3rd admission, and for the same complaint. So this comes under recurrent pneumonia. So I want to ask Dr. Abhay Patel to tell us about recurrent pneumonia. When do you call it as a recurrent pneumonia?
More than 2 episodes in 1 year, or more than 3 episodes with, in between the child is normal.
Right.
It is recurrent pneumonia. If it is a recurrent pneumonia, then the approach should be different. We should look for the other causes also, like allergies, Structural anomalies, anatomical causes, intraluminal, extraluminal causes, vascular causes.
Right. These are the, just to enumerate, these are single lobe causes of recurrent pneumonia, multi-lobe causes of recurrent pneumonias. We have to go through all this. And these are the little pointers in the history. Dr. Mahesh, can you explain what are the pointers in the history of recurrent pneumonias?
Is there a typical age for the recurrent pneumonia is causing? If baby is less than 3 months old, baby can present with a chronic lung disease which is having the prematurity history, low birth weight, baby may be receiving the surfactant for the RDS. And another is the systemic infections, like we can see some viral infection like RSV, like we can picture in the pneumonias. And another thing is the failure to thrive. There are many organic causes like nutrition and any other things we can rule out to pointers for the recurrent pneumonia.
Especially in the surgical cases, lots of history will be there in the history. So coming to Dr. Shrikant sir, how do you diagnose a child with recurrent pneumonia?
See,
What should be done?
first and foremost, madam, if you just go back up 2 slides to the X-ray. So can somebody say, is this a bacterial pneumonia? That is because so sir is right on saying that there is hyperinflation on the left side, but at the same time there is collapse of the right upper lobe on the right side. So any child who comes to you with wheeze, 99% viral. It is not bacterial. So that I have to make it very categorical, because wheeze is a clinical pointer. Say, I'm not saying you do not develop wheezing in bacterial infection. You can, but it is only 1%. But 99% it is always viral. In this particular child, there is this dirty picture on the X-ray. So all the lobes are involved. Yes, right upper lobe, there is fissure pulled, horizontal fissure is pulled up. Yes, it is pulled up. That is giving the right side slightly lesser volume compared to the left side. Definitely yes. That is what sir was mentioning, that left seems to be more hyperinflated because right. So this is classical viral. So if madam is presenting this history, you should always ask for previous 2 chest X-rays and has those X-rays cleared. In this there is no pneumonia only. This is just a collapse because of probable mucus plugging because of viral infection. Only and only if you confirm there is lobar consolidation both the times, and both the times there has to be a documented normal X-ray, then only you start calling it as recurrent pneumonia. Otherwise you don't call it as recurrent pneumonia. So people, what they do is they see this X-ray, next time also a similar X-ray, the third time also similar X-ray, recurrent pneumonia, start investigating. Doesn't go. And at the same time also start asking, why did this child develop? Did the child have any sibling? Sibling is going to school, started preschool, so started developing any infections, and that infection has been transferred to this particular child. So rule out the more commoner causes. Once you rule out the more commoner causes, then you start thinking about the more difficult causes, because for the next difficult causes, investigations are very expensive. You do a primary immunodeficiency panel, that is going to cost you 8,000 rupees. You do a CFTR module, a sweat chloride analysis, that costs you around 6 to 8,000 rupees, and it's not available everywhere. Then you do a high-speed high-speed velocity microscopy for PCD. You start looking at oropharyngeal insufficiency. You start looking at structural anomalies, a CT scan. So cost just keeps increasing significantly. So we can talk about all these things, but even before we go to those things, please be very comprehensive in making sure that this is not a pneumonia or this is a pneumonia. Once you know that it is a pneumonia, you can move forward. So we have had, like sir said, children who have cerebral palsies. They keep coming to us with pneumonias. I am not going to go and do a immunodeficiency for that particular child, because I know because of oropharyngeal insufficiency, they will have swallowing dysfunction. And that swallowing dysfunction will lead to aspiration pneumonias. So I will try treating that aspiration first rather than trying to look at primary immunodeficiency. So that is the reason why it has to be tailored to each patient. You cannot generalize it. And more importantly, please go back to X-rays. Just because somebody has labeled it as recurrent pneumonia, don't believe it. You have to spend time with the child. You have to spend time with the X-rays, investigations. Then only you go ahead and start dealing with
Right.
recurrent
And
pneumonias.
especially
But
in
we
this,
can say it is a persistent pneumonia, no? If it is not cleared out in between.
Absolutely. Then we can say it as
But
persistent.
persistent pneumonia, we can investigate like why it is persisted, which organism, like this condition could be a persistent pneumonia.
along
like.
with that,
But for that, we should have a documented
X-rays,
normal X-ray. If there is no normal X-ray, then it is persistent.
Persistent, yeah.
right. Especially in this child, there was high count with a high CRP and bacteremia also. So we
Adenovirus,
had
madam.
to
We have
super
seen
drink.
in adenovirus, CRP is going up to as high as
Right.
300s.
Right.
So we have never seen those amount of CRPs in our lives. And adenovirus last season kind of rebutted everything that we knew about viruses.
Right.
So it's very important that we start understanding that viruses are going to have very high CRPs,
Right.
and just because there is high CRP, we do not have to rush in doing too many things.
Right. So what is the workup in otherwise a case who has been given treatment and we have labeled it as a recurrent pneumonia, and what are the investigations we should go? I mean, not grossly. I'm
See,
asking.
most important thing that we always think about, see, this is a 8-month-old child. So we are not going to look at a B cell deficiency because mother would have already transmitted immunoglobulins to that particular child. So we always start thinking about a T cell deficiency in this particular child. So in this child, we'll do a TB-NK panel. But at the same time, when you're doing it, you please do of immunoglobulin levels also. But immunoglobulin levels less than 1 year is not something that is going to have value add because maternal antibodies would have been transmitted, and that is not going to value add. At the same time, also ask history about cystic fibrosis. 3 episodes, has oily stools, has failure to thrive, has salt frosting on the skin. Come summer season, child has hyponatremic, hypokalemic metabolic alkalosis with 1 episode of dehydration. You can start thinking about that particular thing. We have seen primary ciliary dyskinesias in children as small as 1 day old. So child who has been on ventilator for a long period, term child on ventilator, there is no reason why child has gone on ventilator. Start thinking about PCD. Child, the newborn who's just born, ventilated, has recurrent collapses. This collapses, the next lung collapses, the next day you keep opening up, still it's collapsing. There is no reason for it. Start thinking about PCDs, early age. Apart from that, child continues to have persistent crackles. Start thinking about PCDs. Child has significant sinopulmonary infections. Start thinking about PCD. In those children, you have to, so in our center we do electron microscopy and we do genetics. We don't have HSVM because we need people to read HSVMs. For cystic fibrosis, we have sweat chloride analysis, and in our center we have a study currently going on where we do genetics for child as well as parents free of cost. So if you have any children who have cystic fibrosis who need a diagnosis, you can send it to our center. We'll let them get their genetic diagnosis free of cost, and if required, we can do the subsequent therapies. And ours is the only center which has started CFTR modulators in children. So ivacaftor, tazecaftor and elexicaftor, which is called as trikafta, is started in those children. But again, it costs money, but we have funding for it. Yes. Apart from that, so we do all the 2000 odd genes. Not only delta 508, we do all the currently which have been documented genetics in cystic fibrosis we do. If a child comes to you with oropharyngeal insufficiency, so we have children who have only difficulty in swallowing liquids. Semi-solids perfectly fine, but only for swallowing liquids. So you start looking at structural anomalies. They have something called as laryngeal cleft, where arytenoids are open. So if a child comes to you with swallowing, not only swallowing, but also whenever a child feeds, there is cough, child becomes cyanosed, child starts having a lot of exacerbations because of that, start thinking about tracheoesophageal fistulas. Or even tracheobronchomalicias, which can cause recurrent aspirations. Congenital lesions, like Sir said, congenital lesions, recurrent pneumonias, persistent pneumonias can be because of CPAMs, sequestrations, or if for a matter of fact, even a vascular ring or a pulmonary sling can cause them. So there are multiple reasons, and again, you have to look at each individual patient. You cannot order all the battery of tests, and more importantly, individualize the test accordingly.
Yes. So for
clearance. Even if the pneumonia is cured and child is better and we repeat the X-ray, there is certain time period to clear that X-ray picture.
That is true. In this child particularly, we gave after initial stabilizing.
Arytenoid clefts, what you talked about, that is only for liquids, not for solids.
No, depends on the type of cleft. If it is type 1 cleft, it is only for liquids. But if it is type 2 cleft, you can have it only for solids, semi-solids and liquids also.
Can we have it in a neonatal period?
Anytime, madam.
Very early neonatal, only milk, then we can't differentiate na solid के लिए है liquid के लिए.
Anytime. So you usually start diagnosing laryngeal clefts only in neonatal period only, because child is drinking milk only, and as soon as child drinks milk, he starts coughing.
Okay.
And child will come to you with recurrent pneumonias. Child will come with recurrent.
Two babies we have, RT feeding, they're okay with the RT feeding. We ruled out H type of deofficial and everything, but not able to drink only.
And there are oropharyngeal insufficiencies which do not have any specific
No, otherwise
cause.
no hypotonia, nothing.
No, there are oropharyngeal insufficiencies which do not have any specific cause.
Okay.
So Cincinnati Children's Hospital has the largest aerodigestive clinic, where they have looked at 1,000 children who have oropharyngeal insufficiencies. 40% did not have any cause.
Okay.
And what got them better was NG tube feeding. So their oropharyngeal area develops by around 4 to 6 months. So until that time, prevention of pneumonia is what they require. Just start them on NG tube feeding, train the mother. They will continue only on NG tube feeding until up to 4 to 6 months. After that, slowly introduce liquids and semi-solids. Child will be perfectly fine.
But in this, you would like to rule out the clefts also, no?
100%, madam.
Rule out. Scope is the only thing to diagnose. Bronchoscopy is the only thing to diagnose that.
Yeah. Other than that, there is nothing. No?
Okay.
You can do, if your center has video fluoroscopic swallowing study, or you are trained in doing functional endoscopic swallowing study, you can do it. Other than that,
scope is the only question. Okay. So in this child particularly, after stabilizing and after giving antibiotics, his counts and all the things were reduced, but clinically on an X-ray, clinically the child still had fever, wheezing was persistent and his oxygen dependency was persistent. So as sir said, there was a collapse on the right upper lobe. So for that we investigated further. His BAL was done, accordingly the antibiotics were stepped up. After that the fever and other parts were reduced, but the wheezing was persistent and oxygen dependency was there. So we got done his CT, we got done his surgical opinion, where the same findings were found, and so we referred this child to you only, sir, for bronchoscopy. And this was the findings of bronchoscopy, where on the posterior wall of the trachea is dynamic and it is compressing over the right bronchus, and the left bronchus is normal.
Sir has done this.
Yeah, that's what I say.
So what we can see is right upper lobe is malaysic. It is not opening only. It is literally closed. The first picture, the second picture and the third picture, what you can see is the right bronchus intermedius is normal, but the right upper lobe bronchus is collapsed. So this is a collapse, not a pneumonia. So any time child has an infection, lung is collapsing, and that is causing the child to have persistent infection. Okay. So this is more of an anatomical defect, but this is going to get better as the age progresses. Just give flu vaccination. If a child is more than 6 months, wait and watch.
Only thing is you have advised to stop all the other nebulizations and only Ipravent and Budicort was allowed. So can you tell the scientific reason for avoiding other nebulizations?
So I think probably learned audience can say, do we use salbutamol or levosalbutamol in children who have malaises?
No. Yes.
Any specific reason for it?
Cholinergic, it loses the tone actually of the...
So smooth muscle relaxant, so it relaxes your smooth muscle even more severely. So it is counterintuitive. So that is the reason when you give salbutamol and there is worsening of your asthma or wheezing, that means child has malaria. Yeah. So you are not supposed to give. So Ipravent is not going to do anything extra. Ipravent is just going to help to relax the smooth muscle by only 5%, and more importantly it helps in airway clearance. So it is given with saline for airway clearance rather than anything else. So it does nothing else apart from that.
Right. But in this child, after giving the therapy, child did very well. This was the X-ray after 2 months, and even clinically child is doing well. He's come with a follow-up and is doing well. Thank you. Any other further thing you want to discuss about tracheobronchomalacia?
So tracheobronchomalacia is something that you see usually after 6 weeks. So any child who comes to you with recurrent wheeze, persistent wheeze, particularly less than 6 months, please start thinking about anatomical defects only. Asthma is very unlikely unless you rule out other possibilities. Second thing is, any child who comes to you and child is absolutely fine when asleep, but child is tachypnic, child is having audible wheeze. Only one type of monophonic wheezing. When the child gets excited, it is tracheomalacia. You don't need to put your scope inside the airways to diagnose tracheomalicias or tracheobronchomalicias. And universally, all tracheobronchomalicias will have reflux. So because they have reflux, please start them on anti-reflux measures for a period of at least 6 weeks to 3 months. Because malicias do get better as the age progresses, because the tracheal cartilages do get better. So you just have to wait it out for the child to get better. And last but not the least, please be very categorical in saying the parents that if the child gets even a single viral infection, child is going to come back with a very bad viral induced wheeze, which will require intubation and ventilation. So, and in these children, nothing works. So, no unnecessary budesonide, no unnecessary Montelukast, nothing. Just counseling. And more importantly, these children are so happily growing. We have 6 months old, 7 kilos, 8 months old, 10 kilos. They are so happy eating all the time. The only thing is they are wheezing. So if you're just able to counsel them, I think they should settle down. Anti-reflux measures, and more importantly, careful, expectant watching.
Where the trick comes, sir, actually these people get when viral infection like any other child. That time this baby is having, bronchomalacia, but this baby got a viral infection. In first X-ray we discuss about it, and then collapse. So that time is a trick. The baby is having adenoviral infection also, the baby is having bronchomalacia. So there is a right upper lobe was collapsed for 2 months together. Now the baby was sent for on oxygen for 2 months at home, and now it got recovered with chest PT and all. So both can coexist. That is a trick here. We have to diagnose. If the viral infection and wheeze is not getting recovered, then we have to think.
No, but what you do not understand in the X-ray is, even the last X-ray there is increased interstitial thickening.
Filtration is there.
If you do
Still
a CT
there.
in this particular child, you will see that there is increased interstitial thickening. So we have seen adenovirus causing PIBO, and that leads to significant hypoxemia, which will go on for months together. So we have to start diagnosing adenoviral induced PIBOs a bit more frequently, because adenovirus is causing PIBO. These children are oxygen dependent, they have recurrent collapses, and more importantly, they continue to be tachypnic. So until unless you start them on something called as FAM therapy, you pulse them with IV MPS, children continue to have symptoms. And more importantly, there are 2 types of bronchiolitis obliterans, obliterative and proliferative. If the child goes into obliterative, we have lost the war.
But IVMPS, where is the role? When, at what time? On the first day only, when we thought there is a effusion transverse band.
So if the child has more than 4 weeks of hypoxemia, child still continues to be crackly, and you have a documented evidence of adenovirus in a nasopharyngeal swab, then this is 100% PIBO. So you have to pulse those children.
We didn't get, and even O2 dependency is there for months together, because this child after discharge also required O2.
So interstitial, that is what
Interstitial.
we have to be worried about in this particular child.
Okay. Any questions in the audience? Like,
yeah, definitely, sir.
okay. So should we?
Adenoiditis. Okay. Sir, obstructive sleep apnea is a completely different ball game. No, adenoids can get infected and it can cause adenoiditis.
Post-COVID, you are getting more patients.
Probably because schools have restarted again. The same, they were not exposed to infections. Now again exposed to multiple infections, so causing significant nasopharyngitis. That nasal symptoms again cause a significant amount of adenoids to swell up. That leading to recurrent adenoiditis is something that we are also seeing quite commonly. But how is a child in between? That is what is more important for us. During an episode, every child is going to have snore. Even when we have nasopharyngitis, we also snore in the night time. But after treatment, until the next episode of a problem, how is the child in between? So nighttime symptoms, snoring, open mouth breathing, frequent tossing and turning, gasping and choking, mouth, teeth grinding, called as bruxism, sleep talking, sleepwalking. Child wakes up in the morning, there's a lot of puffiness around the eyes. Child is very unrefreshed. Wakes up in the morning, very cranky, very irritable. Child was very calm during the COVID times, now has become very disruptive, behavioral issues, lot of temper tantrums, starts hitting everybody at house, lot of behavioral issues. If there are inter-interval symptoms, then you start thinking about adenoidal hypertrophy. And adenoidal hypertrophy can always come back to you as adenoiditis. It can be infectious, it can be non-infectious. Non-infectious, only 1 day fever, child better. Non-infectious are always for 3 to 5 days. And if a child comes to you with recurrent adenoiditis, 1 day fever, and there is inter-interval symptoms, you start always thinking about adenoidal hypertrophy. And depending on the severity, mild, moderate, severe, which we grade on sleep studies, you start them on therapies, conservative or surgical management.
Okay. Should we end this session now? Thank you for the patient listening. This is just apart from our discussion. We had recently been to Kashmir, and this is the Gurez Valley, very unexplored area. The soldiers are taking care of our country at more than 12,000 feet height. Really lovely scene. And when they are fighting so much at such a different and difficult situations, we as pediatricians should at least in very comfortable zone, we have to just treat this case properly, advise them proper treatment, so that we can also contribute to this globe. Thank you.
Thank you.
Sprays for adenoiditis. You can try it as a
Intranasal corticosteroids,
For
definitely. For
3 months, yeah.
mild and moderate adenoidal hypertrophies, ICNS is the
after treating
drug of
infection,
choice.
we can discharge them with the ICS. That
Yeah,
would be
definitely.
Thank you, all the panelists. It was great academic feast today. I thank Dr. Pratibha ma'am for nicely coordinating this respiratory symposium. Listening to Dr. Shrikanta sir was just amazing. We thank him for coming here and elaborating newer things in pulmonology and making us aware of interventional pulmonology. It has given us newer insights in the management of respiratory problems. We also thank for busting the myths and emphasizing what pediatrician must do in childhood asthma. We thank Dr. Sucheta Pofle ma'am for providing knowledge on role of ICS in childhood asthma. I thank Dr. Kundan sir for giving lecture on extremely short notice. Yes, it was impactful lecture from Impact Player. I thank Dr. Sandeep Kulkarni sir for providing details about biofire, its advantages and disadvantages. We thank Meru madam for moderating panel discussion. We also thank Dr. Abhay Patil sir and Dr. Mahesh Arkal sir and Dr. Shrikanta sir again for having great discussion during the panel discussion. Any platform is just incomplete without audience. We are overwhelmed to see so many members joining for this symposium, and most importantly, all were very much interactive. Many have joined from Pandharpur, Dharashiv, Tulzapur, Mohol. We team Solapur IIP 2023 would love to see in upcoming events as well. I would like to make aware audience about our YouTube channel. Please do subscribe that. You can get these lectures again. We thank CIPLA for generously giving academic grants for this symposium. Thank you everyone. After feast to brain, let's have feast to the gut. Thank you.
One announcement from Solapur Academy of Pediatrics. On 1st and 2nd July this year, we are hosting MahaNeocon, that is state level conference of neonatology, which is an NNF event. And also we will be having workshops on 30th of June. Various workshops. All things have been mentioned in the brochures and all will be already you might have received. And I see that many friends of mine have come from far distance like Pandharpur, Mohol and Dharashiv and all. So please see that all pediatricians, all neonatologists from your place get registered to this event. Also, there are many medical colleges like in Dharashi also and all. So they also are requested to enroll their PG students who are there in the medical colleges for these workshops as well as the conference. Thank you.